Welcome, members of the public. Secretary Galley, would you like to say hello? And then I'll run through a few Zoom protocols.
Yeah, thanks, Karen, and good morning to my fellow commissioners. Appreciate your ongoing commitment to this important work, and to everyone from the public as you sort of join in the meeting. Also appreciate your joining. We had a slow start to the commission's year, and I'm pleased to keep us going in this meeting, and look forward to giving you the updates on what's ahead. But before we do that, Karen, could you go through, just remind us how the meeting's going to work, and then just dive right into roll call if you don't mind.
Yes, happy to do that. Thank you. Good morning, all. Just a reminder, this meeting is being recorded, and the video recording will be, the link of which will be posted to the Healthy California for All webpage within the next day or so. Commissioners, welcome. As you know, you have the ability to mute and unmute and to use your cameras, which we appreciate that you're doing. Just a reminder to please mute yourselves when you're not speaking to reduce background noise. Please feel free to use the virtual raise hand feature, or of course we know Secretary Galley loves to call on you as well, and of course just unmute when you're speaking. Members of the public, welcome. We are pleased that you're here to listen in and to view the meeting. We will have a public comment period at the end of this meeting, at which time we will open up the chat feature for written comment. We will also invite you to raise your hand virtually if you'd like to make verbal comment. And of course, you're always welcome to email the commission at healthycaforall@chhs.ca.gov. We will be posting a transcript of all public comment to our webpage as well. We also have the live script feature available to you. You can click on that and use closed captions for this meeting. Okay, moving into roll call. If you could please, commissioners, when I call on you, just unmute and say hello. Well, Secretary Galley, we know you're here, but would you like to say hello?
Yeah, good morning. Thanks, Karen, for having us.
Carmen Comsty.
Good morning, everyone.
Jenny Chin Hansen.
Good morning, everybody.
Bill Shao. Bill, could you unmute?
Yes. Hello, everyone.
Good morning. Richard Scheffler.
Hi, good morning, everyone.
Andy Schneider.
Morning.
Sandra Hernandez.
Morning, everybody.
Sarah Phlox.
Morning.
Kara Desert.
Morning.
Antonia Hernandez. Okay, not able to join us yet. Anthony Wright.
Good morning, all.
Richard Pan.
Present.
Jim Wood.
Good morning.
Michelle Boss.
Good morning.
Don Molds.
Morning.
And has Rupa Maria been able to join us? Okay, we are aware that Bob Ross unfortunately was not able to join us today, and Commissioner Peter Lee will be joining us in about an hour. All right, with that, I will turn things back to you, Secretary Galley.
Great, thanks, Karen, and good morning to everyone once again. I want to dive right into our slides, if we could put those up. So first, I again just want to thank live and over Zoom everyone for their patience during the last couple months. Been a challenging couple months for me with work in the state, with other very important work that has been ongoing. So appreciate the bit of a pause and a delay to allow the time to really work hard on our report. And that gets us to today's meeting. But I wanted to first sort of just outline where we are on our calendar and timeline, some adjustments by the 15th. You all should receive a made public report of our final commission report. I'm pretty enthusiastic about it. It's been a real pleasure to get to craft and work on and try to drive as much of the commission's voice as we have been able to get through. I am pleased with how much how united we are around unified financing. There's a lot of great, I think, information in the report, but also it does raise where there hasn't been 100% agreement and those differing views. So I'm really looking forward to getting that report to you. It will certainly have multiple sections to it, capturing where we've been as a commission, what the conversations and decisions, if you will, have been, really leaning on the important work that has come out of the multiple surveys that we've done, and then leaning forward on a sort of what comes next part of the report, which I'm very eager to get your feedback on. So by early April, we'll ask for your comments back. Those comments will come, we're going to use the same sort of survey style approach to get comments so that we make sure to get very specific feedback on particular sections. Don't worry, there'll be chances to provide sort of more open-ended general comments as well as specific comments, but there are going to be certain parts of the report that I want to make sure commissioners hone in on and give us some feedback on. And then after receiving all of that, we'll have a chance to consolidate those that feedback in a final commission report that we will unveil or release towards the end of April. And then a week after it's released, roughly, we will try to set up a final meeting for all of us to have a conversation about that final report. As with every commission meeting or commission, we know there'll be points where some commissioners will depart from what is in the report, and that's fine. I think in general we want to make sure that we're moving the ball forward, that we're really the points of view that came out of the commission, even if it isn't all spoken with one voice, that we represent the range of voices. So looking forward to getting through this process with all of you. And again, thanks for your patience with it. Next slide. So today there's really our agenda has three components. We're getting through number one now. Before I move on, I do want to mention that because of the really important conversation we had on federal opportunities and authorities and the discussion about waivers versus legislation and what the opportunities are, I asked our team to seek a legal memo on what is potential, what is possible in this realm. I think it's such a key feature of where we go next in understanding what we know today and what's potential for tomorrow. In the final report, that legal memo will be attached. I think it's important for us to process, and you will get a chance to review that as part of the draft report as well. So just wanted to add that as an additional comment as we get prepared for that final report. As I've been working on the report, there are some areas where I really wanted us as a commission to come back to the issues, talk through them again in a bit more granularity, because I think it will help me and our team to get a report that is with fewer holes in it, fill in some of the gaps in the information that I felt we had to date on some very important issues, as well as hopefully come to a clear understanding of where we are as a commission in total on these important issues. So today, our discussion will focus on cost sharing under unified financing, really trying to touch on what some of the challenges are, some of the opportunities, and then really to hear from folks what they think we should include in the report as it relates to cost sharing. And then something we've spent quite a bit of time on already, but it feels like more time is still necessary on this role of the coordinating entities. And I'll share some slides before we get into that conversation that hopefully tease it up for all of you, so you can add to the conversation. And then, as always, we'll end with a period of public comment. And as always, looking forward to hearing what those who have joined have to say about our discussion today. Next slide. So cost sharing under unified financing. This is an issue that I'm raising up. I know that there are some opinions among the commissioners that have already been shared that we want to avoid cost sharing in our plan for unified financing. I know that the various reports that or presentations to date have presented options where cost sharing is an element, and we'll review those in just a minute. But the question for all of you is, when, if at all, should patients, consumers be asked to share part of the cost of care? I think this is an important question that we'll come back to at the very end of this portion after we tee it up a little bit. So go ahead to the next slide, please. So just a little background, rather than share lots of hefty documents, we'll summarize some of it. The RAND health insurance experiment found patients use more healthcare services when they're free at the point of service. That's not a surprise. We also discover that cost sharing didn't necessarily lead to different health outcomes, except for a group of patients that we all have kept at the heart of our conversation, individuals who are lower income, often who face different barriers to care that others don't. We also know that patients themselves aren't always the best at determining which care that has been prescribed or not is quote higher value or lower value, and that that there's a lot to learn about how cost sharing can sort of guide and move patients to care that is of higher value. And then this point on Medicare Part D that shows patients entering the donut hole likely are variable in filling prescriptions, and they suffer worse outcomes as a result. That we know that if cost sharing is part of our equation, that it needs to be used thoughtfully in our design. Next slide. So the cost sharing comparison points we just wanted to put out there. We've talked a bit about actuarial value and how it compares. Just wanted to share sort of in California today how different payers vary with their actual actuarial value of the products that they provide. There's quite a range here. Medi-Cal 100% actuarial value given the low cost sharing, especially for a large number of individuals covered. California, Peter will be joining us, but quite a range depending on the product that a beneficiary enrolls in, and then Medicare and employer sponsored coverage in the mid to high 80s. And again, Don, happy you're with us, CalPERS, with a variety of products, all with various actuarial values. So the point of this is that what people experience today is different and variable, and it sort of matters on how we set up the product and the design, and then how those cost sharing strategies are applied to the individual beneficiaries. Next slide. So like I mentioned, the consulting team modeled 2 scenarios when we reviewed scenarios back in, it was either October or November. We had a scenario where there was no cost sharing, and then another scenario where we had income related cost sharing. Families below 138 of federal poverty level face no cost sharing. Families below between 138 and 400, about 6% of medical expenses, and then higher income families over 400% of FPL would pay on average 15%. The point here was that one of the take homes from that analysis was that roughly $40 billion in new tax revenue would need to be raised if we do a scenario with no cost sharing. So the income related cost sharing scenarios did 2 things. It shifted roughly $20 billion of expenses to the out-of-pocket category. So it's not that the cost went away, it's just borne in a different way. And then roughly $19 billion of additional expenses created by the virtue of not having cost sharing to limit the utilization of services. So roughly 50-50, total of roughly $40 billion in difference in expense. This is material. This is why I wanted to bring the conversation back to all of you to make sure that we land in a place that represents the voice of the commission as much as possible in that next draft report. Next slide. So I did ask Bill Shao, as I have often asked throughout this conversation, both because of his ability to summarize the information succinctly in a way that I think all of us can relate to and find value with, and then the experience that he had in other systems where cost sharing has been used, where maybe it started one way and shifted into another formation so that it drove to different elements. So I asked, before we open it up to a broader conversation with the entire commission, I asked Bill to just share some opening remarks. So Bill, I'll turn it over to you, and in advance, thank you again for helping us have a richer conversation as a commission.
Thanks, Mark. Hello, everyone. Mark asked me to offer a few remarks and examples of cost sharing in single payer systems, and the unified financing is the one type of a single payer system. I want to make clear from the beginning that the ideal single payer system would not have cost sharing. Then I'd like to answer, under what circumstances we would consider it, because just about every country considered it. First is that when you're trying to decide how to fund, let's say, unified financing system, then would cost sharing open up another source of the revenue financing besides the taxation? And because taxation is a burden that also provokes certain kind of or stimulate political oppositions for the new program. Mark already gave you the financial implications of the a unified financing with or without cost sharing. The difference is roughly $40 billion every year. Let me share my experience. When Vermont commissioned my team to design a single payer system for Vermont, what my team did is we consulted all the major stakeholders. In Vermont, that includes labor unions, grassroots organizations, and physicians association, hospitals, big business, small business. And we assessed that people have a certain willingness to pay a new tax for a single payer system, but that the actuarial value of the benefits then can only be about 87%. Meanwhile, there are others pushing for 100% actuarial value or higher. So in our proposal, we made give a benefit of 87%. That means a cost sharing of 13%. That passed the first legislation. In between that legislation and later on, some of the very strong groups raised that actuarial value from 87% to to 96%. Then the commission have heard from former governor of Vermont, Governor Shumlin, tell you that at the end, then the state decided they cannot afford it. So Vermont then did not go ahead implement a single payer system. I just want to tell you, this is what I also went through when Taiwan commissioned my team to design one. And we also had to make the hard choice. When do you actually rely on cost sharing? And in the Taiwan system, there are cost sharing provisions. Roughly, initially was designed with an actuarial value about 85%. And that was passed into law and implemented 30 years ago now. The second reason that some of the single payer systems will consider cost sharing is because it will reduce unnecessary use of medical services. I just listed some of the primary services here on the slide. And let me give you some example of what happened, particularly related to drugs. Drugs is one kind of product, as well as diagnostic tests, particularly the non-invasive ones like imaging, that patients may actually want it, and it may result in overusage. The best example is showing the overuse of antibiotics. Now, of course, when the drug is free, there are a number of studies showing that around the world. And as a result, United Kingdom did not have a cost sharing for drugs and the National Health Service. But then UK decided they had to impose one to reduce the unnecessary use of drugs. Now, let me give you an example of China. China, in one insurance program, offers free drugs. We did a follow-up study and documented 30% of drugs were taken by the patient. These are prescription drugs, but they were never used. They were thrown away. It literally created actually a secondary market in China for these drugs that did not get used by the patient. So I just want, on the office visits, I'd like to illustrate an example of a study done in Palo Alto Clinic in California. This was very early. They had free office visits. Then for financial reasons, they decided to impose, I think, a $5 co-payment per visit. They were surprised the office visit dropped by 25% after $5 visit. So then they decided they were going to increase that co-payment to $10. They found actually that did not change much in utilization. That tells us something that when there's a psychology involved, when people have to dig into, take out their wallet, pay something, they then think more carefully, and the amount may not be that there's such an important determinant of their behavior. The third reason often cited is simply when the funding is limited, when the program cannot satisfy the patient's demand of free care, the single payer system has choose alternative to ration or to limit the services. There are only three common methods used. One is, okay, impose cost sharing. Second is waiting time. And third is when I take it out from the providers, I don't pay them enough, then the quality of care declines. Those are the painful choices. Then let me just highlight, Canada and UK basically choose waiting time, waiting list for selected services. For Vermont, we chose cost sharing. So is Taiwan, design single payer system. But with limits, particularly low income people do not have to pay. Now, in terms of lowering the quality of healthcare by limiting how much you will pay when you don't have enough funds, you can only look at some of the county hospitals when they offer free care before, how their quality declines, as well as waiting time lengthening. That's how rationing is done. So unfortunately, that's a reality of life. That's the painful, but that then stimulated the designers to say, okay, we have to consider cost sharing. Then let me quickly highlight, there are some undesirable effects from cost sharing. As listed on this slide, Mark already mentioned, some people do not know when the service is necessary or unnecessary. So some people actually, because there's cost sharing, forego necessary health services. We do not have a very reliable quantification of that because that usually is done on small groups. The second reason is it compromises the equal financial access principle for a single payer system like unified financing. Let me illustrate a concrete example to show you, even if you exempt the poor people from cost sharing, let's say if you impose a $50 co-payment for imaging tests, that $50 means particular level of financial burden on a person who's earning $50,000. And think of how much a burden would that be on a person who's earning $100,000 each year. So it imposes an unequal financial burden on people with different income or wealth. So you compromise some of this equity principle. And third is, let me quickly on your self-explanatory. If you have to collect the co-payment cost sharing, you have to have bookkeeping, you have to have somebody collect it, you have to have accounting and so forth. That will incur some modest costs. So finally, let me just conclude by putting on my economist hat and say that in reality, countries or states have limited resources for health because there are competing demands for funds for education, affordable housing, income support for low-income households, etc. So policymakers have to decide when you will use cost sharing and knowing there are trade-offs between the desirable and undesirable effects. Then last, I just want to say, international experience also taught us cost sharing measures have to be carefully designed because you want to minimize the adverse effects. So thank you for giving this opportunity to me, Mark. And that's my remark.
Beautiful. Thanks, Bill. Where you ended is certainly the question I want, again, to remind the commission what I'd love for you to think about. When, if ever, is cost sharing appropriate, and what concerns you have. But before we go to general conversation and pull you all in little by little in the conversation, I want to see, Bill, if you wouldn't mind taking some questions, clarifications, any points that folks would love Bill to dig into before we open it up to general comments. So if you have a question for Bill, let's do those first, if you don't mind. And if not, if I don't see anything, then we can jump into the general comments. So Richard and Richard, your hands are up. I see them. Are they for questions to Bill, or are they general comments? No, Richard. Okay, yours is a question?
Yes.
Okay, please go ahead, Richard.
So Bill, thank you so much for your presentation. I guess you referred to certainly the experiences in other countries and so forth. But cost sharing encompasses a lot of different things. So I guess the question is that as we're looking at this, we're so saying it's not binary, cost sharing and no cost sharing. It also, the question is what kind of cost sharing. So I just wanted to know, as you're looking at this, are there, for example, creating cost sharing for chronic disease drugs keeps people from taking them, which actually can increase expenses, right? Because it deters people from getting those filled, even people who are insured. On the other hand, a cost. So I guess that I'm trying to get at is that as people are looking at these studies for cost sharing, are you just doing cost sharing, or are we looking at specific types of cost sharing? Deductibles versus copays and the roles they play, and then of course different types of services as well. So can you drill in a little bit on that? That's the question.
Sure, Richard. You are raising two different questions. One is the kind of cost sharing, and the other kind is where do you actually impose cost sharing? Let me answer the second one first. From the economist's point of view, you want to impose the cost sharing where patients are most sensitive to the prices. They can make the choice based on prices. A drug, empirical study find people have the highest price sensitivity to drugs. But even within drugs, you do not want to impose a cost sharing, let's say on vaccines or on, let's say something which is, let's say treatment of NCDs. But there are other drugs, particularly the overuse of antibiotics or opiates. That would be the kind of choice you want to select. Answer your second question, what type? Yes, there are many types, but the simplest one that people understand and actually respond to, in my observation and from empirical literature, is co-payment. And that's simplest. They understand I have to pay $5 for prescription, or $10, or $10 for office visit. And if I demand MRI for, let's say, when I have to pay $50. And we can get more complicated than that. I will not actually recommend deductibles. That actually is trying to save health insurance company money, because usually the spending is the highest during the, just at the lowest amounts. So I hope I answer your question.
Thank you.
Okay, I am not going to figure out who has a question for Bill and who has a general comment. We're just going to go. If there is a question for Bill in there, and Richard, Richard Pan, I'm gonna consider your hand up if you have a general comment as well. I'll get to you as well. So Richard Scheffler, you first, please, and then I'm gonna go to Carmen, and then Kara, and then Sandra. So go ahead, Richard Scheffler.
Well, thanks, Mark, and Bill, thanks for your presentation. I'd also like to say that I would prefer not to have co-payments and to make the argument of when we need them. And the general notion of when we need them is to deal with the concept of moral hazard, that if people don't pay anything, they tend to overuse things. So it's not only the money, but it's a way of controlling unneeded use. It becomes a definitional question about what's needed and unneeded. And of course, that is a very complicated one. I will say my own personal view is there's an easier way of solving this problem. And also producing the same saving. So what we know is we have a natural, what an economist would call a natural experiment. In the Medicare program, and I'm a member of the Medicare program, you can select a fee-for-service system, which is called traditional Medicare, or as people know, you can select Medicare Advantage, which is in fact some form of an HMO. And there's a competitive process for the plans and the like. And lots of people who pick those are subsidized based on their income. But what's been happening in California is more and more individuals are selecting Medicare Advantage. And in part, it has to do with the aversion to co-payments and deductibles. And the individuals that select them, and I can send the data, but the data is clear, tend to be poorer and from minority groups selecting Medicare Advantage, which has little or no co-payments. If it has any, it might have some for particular drugs, but there's generally zero co-payments, quite frankly. And if we look at California, 62% of the workers, not retirees on Medicare, are in an HMO already. And so they pretty much are not subject to any co-payments, except for some small ones, which might have to do with pharmacy coverage. The Medi-Cal program, which now serves a third, 1 out of 3 individuals in California, is set up as a capitated program. And California is the #1 state using capitated plans in the country. It is in fact the thing that differentiates our model from the rest of the country. And it is basically a capitated model broadly with Medicare, workers, and with people on Medi-Cal who pay little or no co-payments at all. Why do I think this is a good thing? Because there is very good evidence that I'm sure you've seen, but I'll remind you that our capitated system costs 10 to 15% less than a fee-for-service system. So if you take the lower bound of 10% less, and these are objective studies, as many of them. I can send them, but I'm sure the consulting team knows about them. And if you take the fact that we spend 400 billion, you can save 10% of that, which would be, of course, 40 billion, and have no co-payments or virtually no co-payments at all. So I think the question has to do with the delivery system that you're talking about, whether it's a fragmented fee-for-service system, which has no budget and no control, and then you might need a co-payment to do something, or you have a capitated system where you have no co-payments at all, and you can budget it appropriately. And you can also address disparities in the capitation payments. So I'll stop there and turn it over.
Yeah, thanks, Richard. I mean, I think summary is co-payments have their challenges, but you feel like capitated systems produce some savings that are important for us to consider as we think through the costs. And I think it's important to think about both of these levers we have and will in the report, but appreciate that viewpoint. And the point that I think this was also Senator Pan's point. Well, part of it is that how you apply these co-payments matter. Small co-payments for some services might be received differently than larger ones for other services that are important. So I think,
but it would be better not to have any.
Yeah, heard that loud and clear.
As possible, and that's what you would get in a capitated system, and that's why people are picking them and enrolling in them. Not the only reason, but a major one. Surveys show that. Am I saying that these capitated systems are perfect? Absolutely not. They have their problems too, but in a broad sense, dealing with the issue of a co-payment on that, I think they score pretty high.
Great. All right, Carmen, you're up next. Thanks.
Thanks. I just wanted to note, I had some questions about the final draft report, but I'll save those for, I don't know if there's going to be time to ask them. But on the question of cost sharing, you know, I also strongly oppose the inclusion of cost sharing in a unified financing system. I think the three undesirable effects that Professor Shao highlighted are really, really important for us to really focus in on. You know, particularly the fact that cost sharing fundamentally compromises the principle of equity. You know, I think the use of cost sharing, no matter what the purported reason for doing so is, it functions to create an income-based tiers of care where more affluent folks can, you know, who can pay for care, get care, and others are out of luck. And you know, that's this bottom line. That's not a trade-off that I think many people would be willing to take overall. And you know, and it's also not a it's not a long-term solution to the potential issues related to supplies of services or costs. You know, I think, you know, as a non-healthcare professional, cost sharing is incredibly frightening to me because I don't have the skills or knowledge to know you know, what is necessary care or not. I don't know if I have a headache. I don't know, or if it's an aneurysm. You know, like I'm just not going to know. But you know, frankly, like having economic solutions, some sort of behavioral economics as a solution to the issues of use or cost, it means that we're not really having a well-functioning healthcare system if we're focusing on economic theories and psychology of patients rather than health. You know, I think that is really at the fundamental issues of cost sharing. And you know, I think, you know, if we're trying to control costs, again, I think cost sharing is a really bad solution to this question, because, as Professor Shao said, there's administrative costs and administrative burdens, and it places burdens on the system itself to do these types of means testing. Someone's going to have to go and figure out who gets paid $10 versus $50, who hasn't paid their co-pays. There are providers who are going to have to face shaking down struggling families just for $20 out, or they're going to have to deny people care. That's not a system that puts patients or providers in a good position. And I think, if we're trying to address overall costs, I think there are far more equitable ways of addressing cost sharing. Cost sharing essentially is a flat, highly regressive tax. And if we want to capture additional financing, we need to create a more progressive financing structure. This is why the discussion about how to create a financing structure is really important, because if we can find other ways to finance the system where we're not putting the burden on working people, where we're not forcing working people to choose between rent and going to the doctor, between taking their kid to get a diagnostics test versus putting food on the table, we can try to create some other structures that are more progressive. We can try to capture savings by eliminating middlemen, by eliminating the administrative burdens on providers. And I think the last part that I really want to focus on here is that if we're trying to manage the issue of short supply, I'm a little bit more optimistic than Professor Shao. I don't think that we're limited to the things he listed in his presentation. I think if there's a lack of providers to provide certain services, we need to create programs to make sure that doctors and nurses and other healthcare professionals stay in the field and enter it. We need to recruit and retain doctors and nurses and all these professionals. We need to address the distribution issues where we might have a whole bunch of people who are trying to get to one doctor, but other areas there may be folks who have availability. I think in the short term, we can help doctors manage scheduling, provide tools for doctors to provide referrals through their colleagues. I do know in Taiwan, one of the solutions to the supply issue was allowing clinics to open later, to stay open later after normal hours, so that everyone's not trying to go into clinics during office hour to normal business hours. There are things like that we can try to use to address these distribution issues related to supplies, even paying for people who can't access a doctor that's a little bit further away, to pay for their transportation to see a different provider. And then I think the long-term solution of the supply issue is to create targeted programs where we can get more providers to provide services where there are gaps. And from the labor perspective, of course, this is really important to me as someone who represents healthcare workers and who represents nurses. We need to make sure that we're not driving healthcare workers away from their professions because of unsafe and untenable working conditions and practice conditions. We need to make sure that there are safe and healthy and good jobs for our doctors and nurses, so that we can ensure that there's enough supplies to meet the demand. I think reducing the demand by creating these kind of economic sticks is inappropriate, and it can cost people's lives who just don't go to the doctor. So again, I don't, to address Richard Scheffler's point, I think the question of payments is separate and apart from the co-payments and cost sharing question. So I hope we don't confuse those all together, because I don't think one type of payment necessarily has one type of co-payment or not, or cost sharing or deductibles or co-insurance. So I think, I don't want to, I want us to kind of think on a larger level about what are we actually doing when we're saying that we want cost sharing. And I think, you know, fundamentally it's inequitable.
Thanks, Carmen. I think clear point. Kara, you're next, and then Sandra, and then Jim, I'll come to you third.
Thanks so much for your presentation, Bill. Really appreciate it. I know, you know, we have so many goals here that sometimes conflict, and this seems like one of those areas. We want to create an efficient system. We want an accessible system, especially for those who've been historically left behind. And we want a system that improves health overall for California. And so, Bill, I'm wondering if you could talk a little bit, when you talk about reducing unnecessary services. You know, I loved your specific example of antibiotics. You also mentioned in your slide diagnostic tests, office visits, and plastic surgery. I know that we, if we don't do cost sharing, we lose a little on efficiency because we have some services that will be overused. I'm wondering if you can speak to the overall health consequences of those specific services that are most likely to be overused. What are we losing there on the health side? What's the consequence of some folks overusing antibiotics or scheduling a few extra office visits? Talk to us about the health consequences in terms of furthering our goal of moving healthcare forward for Californians. I don't think I'm supportive of cost sharing, but I just want to understand that piece. Thank you.
Or do you have any harder questions?
No, that was it. That's all I got for you.
Well, there are really many researchers trying to do the evaluation, and but of course the conditions differ, and definitely the evaluation that's been done in other countries may not apply to the United States. But within the United States, actually, it varies by income group, by even age group, and so forth. So in the United States, we know we have overuse of antibiotics. And so the trade-off is we may be able to reduce the overuse, but some people may actually forego the necessary drugs that they may use. Then that's why you want to exempt the poor people from paying a copayment, at least protect that group. But let's say for middle income, higher income group people, how much of that actually depends on how much is a patient and doctor monitor the condition, and then take corrective action. Say you have to take the drug. Okay. So I'm sorry, I don't have a general answer for you. We definitely know that non-invasive imaging tests are being overused. Partly it's because we don't have shared clinical records. So you go from one doctor to a family doctor to a specialist, they may repeat the test. That's one part. But that's a different situation. What it is many imaging tests is discretionary to confirm, perhaps, for any kind, remove any doubts about the diagnosis doctors do. But then what's the cost? So if you look at the other countries, like I give you an example of South Korea. South Korea adopted universal coverage, but actually will not cover MRI and CT scan. But did I change it? Usage? No, because they did not control the prices. The physicians can charge the patients for these tests. Actually, they have the highest number of CT scan, MRI tests done in the world. So when you actually, that's why I use the word, you have to carefully design it. You want to look at this part may affect patients' behavior, but you have to really complement with what you have to do on the provider side. Do they have the incentive to do it? Because we as patients, we depend on the doctors to advise us what should be done. And the demand is not purely just on the patient side. Sorry, I give you a complicated answer, but overall, we know the impact. And we also know which one actually is overused. But then what's the negative impact, the magnitude of it? I really do not know of any general answer. And Mark already pointed out earlier, because how do you define necessary? It's a very tricky business in clinical medicine. Thank you.
Great. Kara, I'll just add just quickly on antibiotics in specific. There is a sort of certainly national, but international movement around what they call antibiotic stewardship and using antibiotics appropriately so that we don't breed resistant organisms that then lead to a whole host of other important challenges. So part of it is, and again, we can debate whether cost sharing and copays on antibiotics is the appropriate tool as opposed to better provider training, getting out accurate information about what's working and what's not. This shifts. Different parts of the nation have resistance that other parts don't. So really fine tuning it through other efforts could achieve something similar. But I think adding copays to antibiotics reduces, quote, discretionary use of antibiotics just in a different way. But that's specific on the antibiotic piece. There's a whole set of conversations, as Bill mentioned, around diagnostic procedures, et cetera. So the problem with overuse of antibiotics isn't just we spend more money, we actually have a challenge clinically for patients moving forward. So they're addressing it from a number of different areas. I know some of my colleagues can say even more than I can on that issue, but that's just a quick addition to what Bill shared. Great. Sandra, you're next, and then Jim.
Thank you, Mark. Professor Chow, thank you for laying out a very clear understanding of the various trade-offs. And maybe my question won't be as hard as Kara's, but I'm curious, in the Canadian system, where, as you noted, wait lists are sort of how things are slowed through the system. How would you think about the quality of care that is or is not compromised by virtue of a waiting list type of system?
That's a good question, Sandra. You will notice in England, as well as in Canada, they actually have policy, because the limit on amount of funds available, they select what services could be delayed without really significantly affect the patient's health. And so they purposely did not invest in MRI and CT scan, for example, as well as trained doctors, have enough trained orthopedic surgeons. So if you look at the waiting line approach, it's the country purposely said, with a limited amount of money, I'm going to actually make sure I supply enough doctors, nurses, hospitals, let's say for diabetic, cancer, and heart patients. But for orthopedics, yes, the patient will suffer some inconvenience as well as pain while waiting. But it's not going to necessarily going to really actually kill them. And those are the very difficult choices countries debate and struggle. So I'm glad you asked that question, because you need to make careful selections. And then in Canada, as you particularly mentioned, the waiting time is that then Canada developed a triage system. And that's the primary care doctors have that function. How urgent is this medical condition? It should be seen right away. And patients then are put through a green light. So if you really, let's say if you broke your hip, you can really get treated right away. But if you have a deteriorating hip bone, then that's treated differently. So I'm glad you give me a chance to say these systems of rationing by waiting time is done in a very sophisticated way, and it's not done in general. When it's done well, if you look at England, they also have a triage system, okay? And the waiting time you can see your doctor for temperature or diarrhea faster than you can see a doctor in the United States, both in Canada and in England. And rationing by waiting time is on selected conditions. Thank you.
Great, thanks, Sandra. Thanks, Bill, again for answering all the questions. Jim, you're the last hand I see up now. If others want to jump in next, please do. Go ahead, Jim.
Great, thank you very much, Dr. Galley, and thank you to Dr. Shao. I guess I'd like to make an observation from my personal clinical experience and then ask a question of Dr. Shao. So in my practice for nearly 30 years, we had patients who had copays, and I will say we never shook anybody down. So make that really clear. If somebody came in, didn't have their copay, we saw them. But we noticed, especially with some populations, especially with the Medi-Cal population, that a minor copay of even like $5 was a big tool in ensuring that the patient would actually invest the time to come into the appointment. And the reason I say that is that sometimes when it's completely free, the value to the patient is different. It's expendable. And as a practitioner, to have a patient, a Medi-Cal patient, for example, who had a $5 copay come in was really important to me. When somebody who didn't have a copay didn't come in, that meant I couldn't provide care to someone because I couldn't figure out a way to plan for that. And so while I recognize that it is a potential equity issue, I think it's important to look at the overall health of the system. And because I always I didn't like holes in my day. I practiced dentistry to care for people, and the more people I could care for, the better. And when people didn't show up for an appointment, it got in the way of that, and that's frustrating. So I'm curious, and so my question, what this leads to, Dr. Shao, from your experience and your study, what is the impact of zero copay or zero investment by the patient in the practices of physicians and the overall health of the system?
Jim, you bring up a very important point. When there's no copayment, actually there are studies done, but again, for small populations, to show actually the absentee rate, the non-show rate, much higher. And the economists explain it this way: when you offer something with a they don't have to pay anything. Some patients put a zero value on it. So they say, okay, it's nice, I have it, but oh, I changed my mind and I just won't show up. So there's a whole body of economic theory and some studies to show you have to place some value, or you have to use public education very intensely to educate people. This free service really costs money and costs doctors time and so forth. And so I think you bring up another feature of the why some people argue for cost sharing.
Thank you. Appreciate that.
Yeah, I want to open up your specific point, Jim, also to others to comment on, because I think, Bill, your experience and understanding of the research is important. But you know, Sandra Hernandez, you ran a system I worked in, primarily a Medi-Cal system in San Francisco with a collection of clinics that had a extremely high no-show rate. And then you go to some other systems, different patient populations where you don't see the same no-show rate. Is it the copays? Is it something else? Trying to understand that, because I think having a system that works well for everyone is really important, notwithstanding some of the really important points I thought Carmen brought up. I mean, these are this is what I think we have to grapple with, and this is why I was happy to bring this conversation back. So Richard Pan, I want you to be able to speak to what you were going to raise. Oh, Jenny, I didn't see your hand. I'm sorry. Richard, if I could have Jenny go, her hand was up and then I thought came down. But let's go to Jenny first and then Richard Pan and then open it up. We'll try to do this in another 10 minutes on this before we move on to our next topic, but go ahead, Jenny, and then Richard.
Apologies for my background that mushes my hand up. Thank you, but I'm really appreciative of this last opening and what Commissioner Wood has brought up about thinking about this not only on the focus of the cost sharing, but the context of the ecosystem, you know, and that ecosystem is an example of when a provider has openings because people just don't show, you know, the ecosystem of really the intent of providing care and service is disrupted. So my question, Bill, is part of the ecosystem and the ability, and this is, I know, much harder, but it's part of the structure of providers that I noticed that health plans now, that if direct kind of guide you toward choosing higher performer providers. And if you go to them, there's no copay. But if you pick providers in a lower tier of performance, that there is a copay. Have any of the countries tried to deal with that ecosystem of providing care? That's just another dimension of looking at access, but gearing people toward higher quality performers.
Wow, another tough question. Yes, that's the new thinking, is to really change, let's say, the cost sharing or even the payment rate between people with different performance, providers with different performance. And that's what's been done mostly is through the payment system rather than from the patient side. Because actually there were polls taken much earlier, decades ago, surveys find that patients associate higher price with higher quality. They figure if a provider can charge higher prices, must be better. Just like women buy luxury goods for the same reason. So that kind of a ignorance or lack of information is quite prevalent in the medical field. So we usually do not try to deal with that difference in performance through a different co-insurance or cost sharing. Is trying to actually say we'll pay you more because your performance is better. So the common practice right now throughout the world is even if you pay capitation, you pay 30% is fixed, 30% is based on your performance. Part of that performance quality of care. But that's hard to measure. Let me just say, hard to define, hard to measure. And that's really is quite a difficult subject.
Right,
Okay.
Bill, we'll see if we can get you easier questions, but I doubt it. Thanks, Jenny. Richard Pan, and then Anthony, and I don't see any other hands up, so maybe I'll use that as our transition moment as well.
Thank you. And first of all, I just want to echo what Dr. Wood said. As a physician who cares for Medi-Cal patients on the front lines, who ran a clinic, that the no-show rate in Medi-Cal is very high. And frankly, and I've noticed that Sandra has a note in your head. And actually, so for example, at the clinic I ran at UC Davis, we struggled to get it at the show rate above 50%. And then I thought we were doing really badly until I talked to other clinic directors and other places, and they were doing worse than we were. And we were doing all sorts of things to try to incentivize people to show up. And to be frank, the patients faced lots of challenges getting there. I mean, they already had to pay a cost to try to make the appointment anyway, whether it's transportation, trying to have to juggle the fact that now their appointment now conflicts with when they have to collect their CalWorks check or whatever else, is going on. So it's not all on the patient alone, but still, it was a challenge, and that's waste, in some senses, that's wasted resources, right? We had people sitting there waiting for appointment, and then of course we would do dysfunctional things like overbook intentionally, right? So we could keep up. So I guess, the follow-up is actually my question for Dr. Shao, is that, well, we took care of Medi-Cal patients, and of course now a lot of Medi-Cal are in health plans, but we had fee-for-service Medi-Cal, and what I noticed is that, of course, the Medi-Cal program, even when there wasn't a health plan, made up for the fact that without cost sharing, they imposed other ways to try to control our utilization, right? We had these things called TARs, treatment authorization requests. And we said very appropriate acronym, because basically they put all sort of administrative burdens for every time we wrote a prescription, anytime we ordered something, we'd have to file the paperwork. They'd frequently be rejected because some little niggling, we missed something. I'll just give an example. For hearing tests for children with speech delay, if we I had to turn in a TAR form, I had to turn in a referral form for the hearing test and a prescription for the hearing test, all saying the same thing. And if one piece of paper was missing, then it would be rejected. And it would not be rejected right away. It'd be rejected months later. And then I'd have to go back and then say, okay, what was you missing? And then I'll submit in. So we had to deal with all sorts of administrative hassle as a way to try to keep, and the answer is to keep us from ordering too many. I'm sort of like, well, it's not like we're making money. We don't make any money from making the referrals, okay? There's no financial incentive for making the referrals. We're only making the referrals if we think it's best for the patients. But there was pressure by the system to say, let's reduce those costs, et cetera. The other thing that also happens is what I call volume packing. So what happens is that you have contracts where they tell you, you have to take a certain number of patients all the time, right? And if you don't discharge patients or move them along, so we see this in behavioral health, right? So the behavioral health people tell them you have to take on X number of new patients every week. And that forces them to discharge patients prematurely. But then they say, look, we didn't tell you what to do. All we told you is you have to take patients. And of course, there's only so much capacity you can hang on to your clinic. And then of course you start having, then you just get overwhelmed. So I guess the question I have is that I'm not saying that cost sharing is the answer. Certainly it isn't. But cost sharing is a tool that people use to try, and if they, in the absence of that tool, what do you see especially, government systems imposing other types of controls on providers to in other words, to force them to behave in certain ways to essentially to reduce utilization, not to improve quality of care, but simply to reduce utilization and therefore expense to the system.
I think you already gave the answer, so I will not attempt to give an answer. I would just point out, and by asking a question, why does Medi-Cal impose these rules? And I would suggest that's related to our next topic about what agency you want to run this unified financing. And as well as I will point out, Medi-Cal imposed some of this is partly is because this budget limitation too. But partly is because who runs it. And I encountered this all the time throughout the world. When government runs it, boy, the amount of paperwork, the burden the providers and patients have to go through could be really tremendous.
Oh, thank you. I guess that's our transition.
Well, before we transition, I'm gonna, Anthony, you have your hand up. Love to hear your final comment, and then we will make the transition.
Yeah, so I start with the premise that cost sharing in general is a tax on the poor and the sick. And we talked a lot about the income, but I want to just highlight the sick piece as well, because even a relatively nominal copay of say $25, if you're a senior that has say 6 prescriptions that a month, that all automatically adds up to $150, and that's not that's actually that's pretty darn close to average for seniors on, especially, and many seniors on limited income, right? And lots of examples. And so I just want to be clear-eyed about this. This is somewhat of a interesting conversation and a refreshing conversation about talking what the ideal is, because I think I think we should all recognize just how deeply regressive with regard our current system is with regard to both income and with regard to sick, that we impose a remarkable amount of costs onto it. I think one of the things that we did that I appreciated the modeling, talking about what the average cost would be, and actuarial value is very much an average cost. But as we all know, in healthcare, average is not what people don't experience the system as an average. They experience the system like, oh, I have MS, and I literally have thousands and thousands of dollars of costs associated with having to deal with it. There's years where I may be healthy and I have no cost sharing, and then there's the years by age or accident that I have significant cost sharing. And so I think it's important for us to recognize that. I appreciate that this conversation has, even when there has been divergence, there has been some commonality. So for example, I would say that I have appreciated that we have talked about cost sharing as a fairly blunt instrument with regard, and that we should, this is not where we should start with the conversations about trying to reduce costs. I'm glad that we have not waded into a theory that I don't think has actually been shown, except in very limited circumstances, that the notion that giving costs to consumers is somehow beneficial and allowing them to negotiate prices or to be able to, people are not very good with their own self-triage. People are not very, if it's hard for big purchasers like CalPERS and others to negotiate prices, it's almost impossible for the individual to do so. So I'm glad we're dispensing with those arguments. I do think that, I hope that there's commonality with regard to, I think, Dr. Pan's question about the types of cost sharing. Like, so for example, I would say co-insurance, the notion that, we tell people, oh, you're covered by, 10% of your cost sharing will be 5 or 10% of the cost. But given that people don't really have a sense of how much healthcare actually costs, that 5%, 5, 10, 15% of a lot is a lot. And I find it's almost fraudulent in terms of how, in terms of how consumers experience when they recognize how much a bite that is. I would also put, frankly, deductibles in that category. And I think, Dr. Shah, you sort of said that that doesn't do anything for consumer behavior. It just is the only, I know, I wanted to actually, compliment, I'm glad that Peter has joined us because we have, he has created a space in the, at Covered California, where there is a benefit design process that is not in the corporate, but unique in the country, where it's not in the corporate boardroom. It is done in a more in a process with other stakeholders and other and when we have to make decisions about deductibles, it's the only real quote unquote benefit of it is to as a trade-off with the premium, or in the case of a unified system, it would be through our financing mechanism of whether it's taxes or other revenue sources. But there's no other, I think, real benefit to that. And I want to compliment our two health committee chairs for working on legislation this year to try to provide state subsidies to eliminate those deductibles in Covered California. With regard to nominal cost sharing, I still think that there are the issues that Carmen raised with regard to simplicity, with regard to just ease of use. And I hope that there's commonality on the issue of low income folks being exempt from this, that even a few dollars has a big impact on there. And I totally appreciate the issues of no-show. I'm not sure that imposing a cost for low income is the thing. Like, it almost seems like it's the reverse. Like, I think that obviously from a practitioner point of view, you see the people who don't show up. I'm also concerned about the people who don't schedule in the first place because of the costs. And I do think that the RAND study did show that cost sharing does have an impact there. My final, especially with low income folks, and again, people are not good about differentiating between what is necessary care and unnecessary care. And that has a big impact, especially where people are most sensitive to it, which is on the lower income side. So again, I think, I just, in the last couple of weeks, I was on an athletic field. There was a collision, it looked like they cracked their ribs. And I saw in real time, people discussing like whether the person should go to an urgent care or ER or not go at all. And they were literally discussing like, oh, but if you go there, it's $200. If you go there, like they were having that real time discussion of talking about that financial barrier. And I think these are decisions that people make real every day. And so, I hope that there is, I think that there is spaces for commonality here in a variety of things. And even when there's not, I do think that, the cost sharing is sort of a last resort rather than the first. And if it is, it should be the nominal, like I do think. And so I wanted to ask Bill Shao just this question, which is, number one, I thought it was instructive that yes, there was a change from 0 to 5, but not from 5 to 10. And I thought that sort of indicates that maybe you can move forward with, if you were to do this, it should be relatively small as a signal rather than as an actual impact. And again, excluding the low income. And then, and I've found that there's not a ton of literature on what we've found that people are experiencing right now, which is the really high deductibles that people are starting to, is now becoming more and more common, even in employer and commercial employer-based coverage. And I don't know if, you have, if there is maybe more literature that I'm aware of with regard to the impacts of that.
I'm sorry, I don't, but I can tell you, United States have high deductibles. It's because it was pushed by President Bush. Actually, is give particularly workers a choice. You can actually get a savings account, health savings account, and but then you take $1,000 up to $3,000 deductible per person. And some of the workers did select that. I was opposed to that. I used Singapore as an example, showed what happened, the adverse effects, but it did not influence policy in America.
Thanks, Anthony, and I appreciate some of the summary that you provided as well of the conversation. Don, your hand was up and then came down. Want to give you a chance if you want to make a comment.
Yeah, I was feeling rude because I know you're trying to move on, but I'll be.
No, I mean, look, this is why I brought this issue back.
Yeah.
I feel like there's just a lot to say on it. It's going to come up as we think about the future. This will rear its head one way or the other. And it was important for me to get your collective feedback. So jump in, Don, please.
Yeah. So a couple things. One is, and not to push Commonwealth Fund research, but Commonwealth Fund has done a lot of work in this space, and so I would encourage you to look at that. It shows some pretty devastating effects of what they refer to as delayed care because of cost. You see it also pretty negative effects even in the Medicare program. So so you have seniors, and they benchmark these and look at their international studies. They're benchmarking international studies in particular, but they're able to memorialize a lot of pretty negative health consequences from the cost sharing and Medicare program. I do think it's really smart, if you're going to go this direction, obviously, to stagger it based on income, but you want to make sure that you get that right. And I'm not sure that 400% is the magic number there. So so you just are going to want to look at that hard if that's the direction you want to go. The other thing, and this is more of just a political observation, but you know, so the other thing that when people are looking at this and deciding how they feel about it, one of the things they do is they look at what they're paying now, right? And they compare it to what they're paying in the future. So you noted that people with employer-based coverage are at 89% of AV. Somebody with a CalPERS HMO is up close to 97% of AV, actually. So if you're looking at 15% cost sharing or even 6% cost sharing, you're going to end up paying more. And I just think politically that's going to be a real problem. So just, you know, you either need to think about supplemental products at that point to make people, that would make people whole. I know that there are very mixed feelings about supplemental products among this group, or just changing the cost sharing just because of those concerns.
Don, that was worth waiting for. Thank you for making sure you added those comments. I think, like I said, very rich set of points, Anthony. I think you're right. There's a lot in common here. And I mean, I heard a lot of caution around cost sharing. I heard a lot of, if you have to consider this, consider that, some very legitimate things that we're trying to control, like thoughtful utilization of our services, whether those are appointments or procedures, and that cost sharing sometimes is used as a tool to try to control those or make it more efficient, and not clear whether that's the best way to do it. And we shouldn't just assume that you get the outcome we think we're getting by invoking a cost sharing strategy. So lots of appreciation for the wide-ranging conversation. Bill, to you, thank you for teeing us up, and as always, being the professor here, answering the questions. And appreciate that. So I want to transition. I'm going to ask the team to put the slides back up. Just want to do a quick time check. Really want us to wrap up at noon so we can leave maybe 12:10, leave some time for public comment. And Carmen asked a question about can we have a brief conversation or just have some space to ask some questions about the final report. Carmen, I'll try to wrap this up maybe 10 minutes till, or just right at noon, and give us 10 minutes to at least ask some questions from the commission about the final report. Apologize that hasn't been provided as of yet. So diving into this sort of other conversation that in some ways is a little meatier. We've had a lot of discussion about it already. We've sometimes talked about it as the role of health plans, health systems, but really I want to talk about it as the role of coordinating entities. And you'll see in a moment what I mean specifically by that. And the question here for folks is, how is care organized and coordinated under unified financing? And so hopefully the next couple of slides will tee that up a bit more. Can I get the next slide, please? So we've heard in the conversations that some folks are in favor of a plan function, just a really different kind of function for plans than what they do today. Others say, no, we don't need the plan. They just serve as a middleman. And frankly, anybody else who sort of imposters as a plan also isn't needed. And I think today, my hope, especially as I've been struggling through this part of the report, really sort of landing on what are the options for taking care of the issues in the middle box, or in the middle bubble cloud. So if we look at this as 3 levels, we know that there'll be a statewide unified financing authority. I think, Bill, you said, well, when it's led by government, there's some administrative burdens that come with government, and then there's maybe some other options. So without debating who runs that for a moment, let's just assume it is a governmental entity. These are the things that I think we're establishing as the responsibilities of that unifying financing authority. The next piece is to look down at the very bottom right. What do the providers, the physicians, institutions, health groups do in this regard? They provide clearly the clinical care for individuals. And then they have to report data. They may not be responsible for sharing all of the data broadly, but there is some component of data reporting at a minimum. So then we have this middle box or cloud where there's issues around care coordination. There's issues about quality and quality improvement. There is the work that we are focused on with population health and driving towards certain disparity reductions, ensuring that equity principles are followed and that we're tracking inequities that are derived from and result as because of the structure of some of the entities that we have today. Also thinking through, the implementation of things like global budgeting or different initiatives around disease-specific efforts. How do we, where do those functions land and who's best suited to do them, I think is really an important open question. I can imagine there'll be a lot of dialogue on this, and wanna, before we jump into it, go to the next slide. So these are the things, just to dig a little bit more into what the state unifying, the Unified Financing Authority would be responsible for. Determining benefits. We wouldn't leave that to someone else for a lot of reasons this group has discussed, and really thinking over time how benefits change as technology and innovation happen in healthcare. Second thing is confirming eligibility based on residency. This would be a program for Californians, but there's some important issues that have to be grappled with. What happens when a Californian is out of the state? What happens when a Californian's temporarily living somewhere else? All of those issues. Established payments, we've talked about that. sort of not just the form of the payment and who gets paid, but the rates. And then ensuring that any form and scheme around equity-related payments and or any adjustments based on those equity-related principles gets implemented thoughtfully and consistently. This, we believe, is an important role. Also, the ability to collect and make public data on quality, access, equity that can certainly help drive maybe consumer decision-making on the one hand, but also overall program oversight and the integrity of the program altogether. Some other areas, the managing grievances and appeals. This is a whole set of work that many of us are familiar with, having the various differences in how these get implemented today is both confusing for consumers, pretty inefficient. Managing this centrally seems important. And then not lastly, but certainly one of the last things that came to mind for us is continuing to monitor and address health disparities, key functions for that authority that we've been talking about creating as part of this entire scheme. Next slide. So some key questions here. Under the status quo, we have multiple payers, fragmentation, and it's hard to do these things, but we often lean on different coordinating entities, health plans in this case, to drive quality improvement programs, to take responsibility for care management initiatives, and then for coming up with and then implementing new approaches to delivering care. We experienced this quite a bit during the pandemic. We saw a flip on the dime of how much virtual care was being provided. A lot of that happened because of the capabilities and technology at the provider level, but it was facilitated and permitted through things done at the state, but then executed and implemented through plans. And I think we all became familiar with that. In the question really under unified financing of how, by what entities should these efforts be controlled, be the responsibility of, and certainly a focus of our discussions has been on who should and how do we make sure care is well coordinated, not just at the highest levels that we have complete visibility, but really at the patient level, how do they experience well coordinated care as a result of the structures that we create? So if health plans or health systems were used as care coordinating entities, how could they be reimagined to provide higher quality and better coordinated care? If health plans were not used and health systems were not used as these entities, who should be used? Where do they live? How do they relate to the Unified Financing Authority? And if not, which of the two entities that we have left, the Unified Financing Authority or the providers, the direct providers, would take on these functions? And then as an important question that I think is very applicable to the state as diverse as California, that is sized like California, do we think about this in a regional way with sub-authorities? I mean, Bill, you talked about where Vermont was. Vermont's a state fraction of the size of California. Practically speaking, when you think about these important functions, is it better to have it be more regional to pay attention to some of the unique opportunities and challenges that might be in the northern versus the southern part of the state, or rural California versus coastal California? So these are some of the key questions that I wanted us to dig into. Next slide. So as part of this discussion, I want to maybe begin by asking the clinical folks on the commission to weigh in. So specifically, Dr. Pan, Wood, Hernandez are with us today. I know we're missing Dr. Ross and Maria, but I am curious for you three, and then open it up to broader discussion. And I'm going to pull you in, Peter, a little bit, because I want you to be able to reflect on some of the transformative work you've done around the role of health plans, what they see as their key responsibilities, and how that has gone. It covered California. But to begin, maybe Sandra, I can put you on the spot first, turn to Jim and Richard as well. How do you think both the clinicians, what do you think their role should be in this? How broad should it be? How, what would they need as tools and supports to do more than they do today to deliver on some of these important functions that sometimes in our today's world plans do, and in a future world we are going to call on someone to do because they're necessary?
Yeah, thanks, Mark. They are necessary, so I would just want to stipulate to that. We really do, as was said in our earlier conversations, it's really hard to put the onus on patients to sort of figure out how to best coordinate their care. So I would just stipulate to that. As to providers, I think it's a little bit of a non-binary conversation. On the one hand, in a very fragmented system as we have now, it's very hard for medical groups, et cetera, to look up and do the right thing when the right thing is coming from 4 or 5 different payers with different expectations and the like. And it's also true that in a pure fee-for-service system, the financial incentives are to do more, not necessarily to do better. So my view is that better tools would include, for example, things that we're starting to build, right? A data system that allows providers to more readily share in real time useful information about healthcare needs, where people have been seen, what's been prescribed, what's been ordered. So the data infrastructure that the state is working on, to me, is an integral piece, not just for providers to put input into, but to extract useful information in a timely way to make really good decisions. So I think and by the way, we have a number of providers, many providers in the state that don't have access even to basic information tools. And we need those providers to be brought in, something that the data exchange group is working on. So I definitely think there are tools, but I don't think you can leave this entirely to the delivery system to sort out, Mark. Better tools, better training, better data exchange, and whatever the finances are, we obviously want the incentives to incent people for population-based health. We want to incent people to actively reduce disparities. We want to incent people to really collect the racial ethnic data that we need to be able to target resources in an appropriate way. So there's a lot of things to build that would make the delivery system a lot more efficient, not the least of which not having to look up at multiple payers and to try to sort that out. So that would be me wearing my provider clinic hat. And, even building systems where, you'd have the STDs in one place. And, I can't state vehemently enough the tools of information. And COVID showed you this, and you referenced this, Mark, the ability to have that information, whether it's public health data, whether it's immunization data, those systems really are instrumental for us to get a delivery system that does the right thing by patients. Because frankly, as a clinician, everybody that's a clinician on the screen is trying to do the right thing by patients when they're with us. And then the last thing I'd say, because I'd be a poorly trained primary care physician if I didn't say this, I do like, and Professor Chow in our earlier conversation, as you think about a system where there's some version of triaging, or if we don't go with copays, we find something else. Primary care providers really do need to be the place where the decisions are made with regard to what scan you need, what diagnostic you need, what combination of pharmaceuticals you might need. And so I would want to incent a system that creates the right incentives at that level of care, because I think that ideally looks across the wholeness of a patient to be able to make the right decisions at any one given time. So I hope that's helpful, Mark.
No, it is well stated, well put on many points. Thanks, Sandra. Richard, can I call on you next?
Sure, thank you, and appreciate what Dr. Hernandez said. So, as a primary care pediatrician who particularly specializes in children with behavioral issues and children with special health care needs, I find, I think that, a couple of points I'd make. First of all, when you look at the research on medical home and primary care from people like Barbara Starfield and so forth, the coordination of care, the closer you can get to the front line, to the actual physician on the front line, that is the best way to do it. So we've seen models where it's done like disease management, it's done by a health plan or something, and it's disconnected from the primary care physician. Those tend to be failures. When you look at the models, for example, like North Carolina's Medi-Cal program, where it actually gave payments to the primary care physicians to try to do coordination of care, where they're allowed to work together and pool those funds those were much more successul. So I think, when it comes to coordination of care, as much as we can get the resources to the front line, that's going to be really important. I also agree, though, is that we have to provide the infrastructure, so that includes the information, et cetera, as well. The other thing I would also make note, though, is that you start with the role of state UF authority, and then you talk about care coordination, care delivery. You can't separate the payment from the care coordination part. All right, so you can't have the payment go in one place and then the care coordination and care delivery on the other. Because when we talk about incentives, we've talked about fee for service versus capitation and so forth. Well, if you can't have one entity setting rates and then the other entity trying to get people together and then not having an ability to actually structure the finances in the appropriate way, right? Those financial incentives that actually Dr. Hernandez just talked about. So I am a little concerned that we are splitting the two here. And in fact, the other question is, you said establish payment rates versus negotiate payment rates is a big distinction. So, we saw how Medi-Cal essentially established rates, and, I was in the legislature, so we had to cut rates during the Great Recession. And we did it with regard to the budget, not with regard to the healthcare outcomes. And so that's something we have to deal with as well. Now that we have everybody, if we're going to put everybody under one umbrella, unified financing, then the payment needs to be, it has to be assured. We can't have budget up and downs. It needs to be an entitlement. And we haven't, so I know we haven't, hopefully we'll, in that report that will touch on that. But then the other thing is who are we establishing payment rates for, right? Are we going to, for every visit, for every doctor, hospital, et cetera? Are we going to do, groups, et cetera? So I do think I'm low, this thing about care coordination and payments in two separate entities is not, it raises a lot of questions about how that's going to be done in a way that's going to actually lead to the outcomes you want. Because we talk about value-based payment, other types of things, those things go together. And then also, of course, you need to finance that infrastructure, right? The IT infrastructure, the other types of things. And then how do you give the resources? It's not just about paying the doctor, right? The primary care doctor. It's about having them have control over the resources in order to help with the rest of the healthcare team, right? Because you're not just financing the doctor, financing the healthcare team, that they have the oversight over the resources to be able to build that coordination, right? And working with whatever intermediary entity. So I do think that that's something to think about as well. It's not just about paying individual professionals or healthcare institutions, about who actually is overseeing, who actually has the oversight over those resources. And are we giving the people on the front line sufficient oversight over those resources to be able to do the things that we want them to do, right? So being sure that they can build, that they are providing care in a coordinated team, and not just for common diseases, because you have a lot of people who have fairly rare diseases. So we can build out a system for asthma and diabetes and so forth. And then you got the people who have these diseases that are sort of in between, right? And so someone may have to build out a somewhat unique network of specialists, therapists, other types, et cetera, social, because that disease isn't that common. And so, and of course you have variations in patients as well. So I guess I would say in summary, we need to be sure the frontline physician, the primary care doctor, not only has adequate payment, but they also have control over the types of resources necessary to build out that coordinated system. And then we need to provide the infrastructure, the IT systems, the other things, et cetera, as well, to also support that type of activity. So it's going to be a balance between, where we devote the resources for building the infrastructure, I guess the coordination care, and then also being sure that the frontline caretakers actually have the resources that they can manage, with the patients, to be sure that the patients can get the coordinated care they need.
Okay, thanks. I think building that comment helps support and builds on what Sandra shared. Jim Wood, I'm not sure if I can pull you into the conversation. We can also come back. All right. Okay, I'll pull Jim in a little bit. Peter Lee, I was hoping to put you on the spot. Just I think the work Covered California has done really under your leadership, and has been tremendous. Been proud to be part of some of that work with Sandra and others. But if you wouldn't mind sharing sort of what you've seen, even in 10 years, how this has evolved, where it can go, and what you think about this question on coordinating entity and their role and where it belongs.
Great, happy to. And Mark, if I could, I want to spend 2 minutes jumping backwards to the prior discussion about benefits and cost sharing, and alluding to some of Anthony's remarks, which I think were spot on, is that the issue about cost sharing and benefit design is an issue that has to fundamentally look at the income levels of where people are and what costs are to them to have as few burdens as possible. And I just want to note that most Americans do not have that by any means. If you are in a Medicare Advantage plan or an employer coverage, there are not standard benefit designs. Benefit designs are confusing, non-standardized, and obfuscate what your care options are. In Medi-Cal, that's not the case, because there's a standard designs with no copays. In Covered California, there's standard benefit designs, and both premiums and your out-of-pocket is tied directly to your income. Now, there's a good discussion, should it be zero for everyone, and where's zero? But there's no question that lower income people should be paying much, much less. The more they pay, the more they will not be getting needed care. And so just as a fundamental thing, we, in our non-unified system, have a boatload of people with coverage that too often is coverage only in name. Coverage in employer coverage, 30% of whom are undercovered, and about 35% of people in Medicare are spending 20% of their income on healthcare coverage. So that's just a flag. And so I think that some of the core elements of having standard designs and income adjusted, both what you pay out of pocket to see a doctor or get care, and what you contribute on a monthly basis, if it's not disappearing, just fundamental issues. Second, let me just do it sort of a high level, some observations as it relates to care coordination and what it takes and what we've learned. And I do apologize, Mark, I'll be a little bit more diagnostic than treatment plan. And I just want to remind us all, though, of a couple things. The point of unified financing isn't coverage. It's people get the right care at the right time, given their personal circumstance situation. And we've made great progress in the nation on coverage in the last 10 years in particular. We have done an abysmal job at improving healthcare quality in the last 20 years. I just want to just, many of us are familiar with the Crossing the Quality Chasm report. It came out 20 years ago. At that point, people like Beth McGlynn said, the chances of you're getting the right care at the right time are a coin toss. 55% of the time you're getting the right care, 45% you're not. In the last 20 years, it has not improved. Your likelihood of getting the right care as a diabetic, as a person with heart disease, has been consistently poor. Whether you have individual coverage, employer coverage, Medi-Cal. What's the evidence say? And this does come to the center of your cloud chart, Mark, on your prior slide. There is strong evidence that you are much more apt to get higher quality care that is responsive to people's personal differences by ethnicity if you are in an effectively coordinated, integrated setting. There is very strong evidence that if you are in a non-integrated setting, more fee-for-service, more PPOs, which sadly is where most of the nation is going, you get worse care. You are more likely to die of diabetes. You are more likely to die of heart disease if you are in a quote unquote PPO or a fee-for-service, pick any doctor you want system. Let me bring that home to California. And Mark, you alluded to Cover California. Our board just approved new contract terms for our 11 health plans, maybe to be more, that will put very substantial financial consequences at stake for health plans if they don't improve care in 4 core measures. While looking at other issues, but I think Dr. Pan's point is incredibly important. Focus on core issues like heart disease, leading cause of death in California, diabetes, 40% of our Californians are diabetic or pre-diabetic, but don't ignore other things that affect fewer people but are serious. But in that, we're putting big money on heart disease, diabetes, colorectal cancer, and childhood immunization. Now, amongst our 11 health plans, Kaiser is actually in the 90th percentile nationally in 3 of those measures and above 50th in the other one. 90th percentile, and they can do better. Other plans, way lower, and in particular PPO plans are often below the 25th percentile. People are dying because of poor care, less integrated care. So I just want to be, as a fundamental issue for a solution which is you consumer, go find a doctor and pick from anyone, is a prescription for worse quality care for the most disadvantaged people. So the path is 2 things, to my mind, is one, and this is what a number of the, both Sandra and Richard alluded to, the issue is we need to have care that is coordinated and cuts across primary care to specialty care to hospital care. It's about data on drugs. It's about data on when someone leaves a hospital, but it's about coordination. And the issue is, how do we make sure we are, one, having coordinators of care, and primary care is part of that coordination, not the endpoint. Now they are the anchor and foundation, but to expect a primary care office to understand all aspects of the full spectrum, I think you ain't gonna have it. The best example, which I know some may have problems with, but we have in California, is Kaiser. Kaiser today, blood pressure, hypertension is not the leading cause of death for people in Kaiser. It is for the rest of Californians. Why? As a system, they've addressed doing the right thing for patients on a regular basis. Cancer is the #1 cause of death. We should be expecting that of the delivery system. And I think the answer is system. Now, what's the system? This comes back to the question of, the term you use of coordinating entities. It is an entity issue. If it's a plan needs to actually own coordination from end to end of the patients with what we now have multiple signals, as Sandra noted well. You got, 10 health plans in California represent 90% of all coverage. But if you're a medical group, and remember, and Mark, I really appreciated your note on the bottom right of your other chart was physicians. Virtually all physicians are in groups. So we already have medical group-based practice. Some of those groups have hundreds of doctors, some have fewer. Those groups have not just doctors in them, but have nurses, have behavioral therapists, as they should. Care of people is about behavioral health issues. Care of people is about getting to the specialist at the right time and getting back out. I think our charge is, in the near term, one, having payment that is about having consequences to those plans out there today. We're doing that. Over the longer term, it is moving dramatically away from fee-for-service payments. Fee-for-service is widget care, and it rewards more, and it encourages disintegration of care. The more we have payments that are moving towards care for populations and holding the holder of those funds accountable and responsible for that care, the better we're going to be. Is that a integrated delivery plan like a Kaiser? Is it a accountable care organization such as delivering a portion of care through Medicare Advantage? I'm not sure. But I would note that health plans today, those that aren't integrated, haven't proven that they can be the engines of quality improvement. They've proven they can be the engines of getting more people covered, and to be at coin toss coverage, coin toss care, which we've been at for the last 20 years. But if plans don't get to thinking instead about the commons of diabetics in a community, rather than a health plan's diabetics they're caring for a little bit of time, we won't have workable solutions. So that's a little bit more on diagnosis than treatment plan, Mark. I'm not sure that's what you're looking for, but I do think that in all the discussions I've heard so far in this commission, which have been really fruitful, the thing that does worry me the most is the idea that, oh, the solution is to go back to 40 years ago of fee-for-service Medicare, and everyone get that. That's a recipe for non-coordination, which is what consumers need. And that's the place that I think we need to be in the future, of having systems of care that go soup to nuts, from mental health to behavioral issues to primary specialty care, hospital in and out. So, happy to take either questions, reactions, but it is a matter of holding to account those that we are giving the responsibility to care for our both well and sick individuals.
No, I appreciate it. It's important to just get a sense of who's sort of done well with this, and the fact that we unfortunately haven't made the kind of progress that we should have as a nation in this area over the past 2 decades. So thanks, Peter, for your leadership on those efforts. Jenny, I want to go to you next. Your hand was up next, but also I think it's good to follow Peter in a way, because you've been closely affiliated with an entity that in many ways blurs the line between plan and provider in some ways, and just would love to hear a little bit of your feedback based on your experience with PACE.
Well, thank you very much, Mark. And Peter, I cannot endorse more of all, frankly, your points that you have made. And I really concur with them wholeheartedly, and in a way that actually helps us. Perhaps if we can put up slide number 14 again, which is the slide that Peter had alluded to, of hoping that we have a way to bring in primary care, other physician providers, the kinds of needs that we have. And I want to first of all acknowledge a fellow commissioner here, and that is Andy Schneider, who was very key in the work that we did to move a program here in San Francisco called Unlock to become the PACE program that is now in legislation federally under Medicare with an option to Medicaid. And this this model right now actually encompasses all three subsets of information in in this particular slide of having payment rates, data monitoring, grievances and appeals, and implicit in it is a whole system of what's in the middle of coordination, quality improvement, and physicians, both primary, specialty care, even dental, behavioral health, and all, and long-term services and supports in this PACE model. The PACE stands for Program of All-Inclusive Care for Elders. And what I jotted a quick note to Mark about is just this last week, there is work being done at the national level by the Bipartisan Policy Center that has chosen to take PACE as one of these models right now that exists in 31 states to really begin to figure out how to have this model, which actually encompasses not just a health plan, but the providers. So to your point, Mark, this merges two elements here. The providers who are directly working with the enrollees, and at the same time, it acts as a plan that incorporates the first two elements here on this particular chart. And so there's a report that's going to be coming out from this, because this sense of this muddled entity, which is plan and provider, may be one way to think about all the elements of doing this, and especially because the focus has historically been on dual eligibles, those eligible for both Medicare and Medi-Cal. And we have many PACE programs in the state here currently, but also what is moving ahead at the national level is there's bipartisan legislation to address lower middle income populations and the cost of pharmaceuticals for the middle income. So just wanted to place a bookmark that there are models here. This program has actually passed federal legislation 24 years ago. And so, but it does take decades of work to move it. And so I just want to not forget something that we have a bird in hand as an opportunity, as a system to take a look at, to see its relevance for achieving these principles and elements that are on this slide here. So I just wanted not to forget that we don't always have to reinvent. Sometimes we have to rediscover.
Thanks, Jenny. Super helpful. Could I have the team take the slide down so I could see everyone? Thank you. So building on that, Michelle, I want to come to you, and then Carmen, you're after Michelle.
So I would just note, if we're really wanting to reimagine what a coordinating entity would do or could do, I think I would even want us to push a little further and just note that for so many of our vulnerable Californians, we know that health is driven by more than healthcare. And so I would see this coordinating entity really also coordinating some of the social drivers, food insecurity, housing, respite, et cetera. And I know we're trying to do this on the Medi-Cal side with CalAIM and the new managed care contract, but really trying to push the boundaries of who, what's that entity that can connect the dots to ensure that a person has the opportunity for good health outcomes, I think would be something that I would encourage.
Yeah, that's a important opportunity and feature. I think that the commission has talked about how health services can't do things alone, but connecting dots and having somebody in charge of bringing those other human services. If I think across my agency, Michelle, you're part of that bigger group. I think it's an important concept. So thank you for adding that. Carmen, you have certainly in other conversations really pushed us to think of a world without plans that we have a direct. And so I'm interested in hearing sort of how you see this landing and how that coordinating function lands in one of the two other boxes in your mind, or how it fits together. So thanks for your comments.
Yeah, thanks for bringing this topic up again. I think I want to reiterate some of the points that I've made previously, but I think what's helpful here is to kind of clarify what at a definitional level, what do we really mean by care coordination? I think I think Senator Pan had a good explanation of what that is, that it's really at the provider level. What we're talking about is that people on your care team, your doctors, your nurses, your other healthcare providers that are on your team, to make sure that those people are working together, that they're communicating together, that they're sharing information as necessary, and that they are working together to provide you the best care for your individual needs, and that everybody is coordinating and adhering to your individualized care plan. And of course it could be information sharing, it could be doctors and other providers just being aware of the other diagnoses that you have, what specialists that you're using, what prescription drugs that you have, what tests, we talked about this earlier, what tests you've already gotten. If you have a scan, make sure that everybody on your team has the scan. Making sure that you have the appropriate referrals to specialists. And I think what was important with what Senator Pan said is that it's best, care coordination best happens when it's done by your care team directly. So this is why I think there's a fundamental question about, what is the value, what is the benefit that an entity doing this type of coordination does? And I think we had to fundamentally ask ourselves that question. And to kind of broaden the discussion out again, when we're talking about entities, I hear I think we've had different definitions about what this, entity that's doing care coordination is, but I think fundamentally most of us think that those would be some sort of corporation or corporate structure or corporate relationship between, and a health plan, or it could be an ACO where doctor groups are interested as risk-bearing entities, but it's really a legal type of situation when we're talking about entities and care coordination entities, because at the end of the day, care coordination can be done by doctors picking up the phone, by doctors being able to access scans, those types of things. And I think that's really what I'm trying to challenge us to figure out. How can we do that without having this other type of corporate structure to say, well, actually, I'm a insurance plan administrator, I'm a plan administrator, and actually we want you to do care this way or that way. So we have these unlicensed professionals making decisions on what the care should be. So I think that's why there's a fundamental problem with using kind of these business interests, these corporate interests of risk-bearing systems, risk-bearing corporations to achieve care coordination, because at the end of the day, that's not what their goal is as risk-bearing entities. We are, their goal as corporations is to have returns for their corporate structure. Shareholders, if it's a for-profit, the corporation as a whole, if they're a nonprofit. But that is the goal of businesses, and we have to really understand that's what we're talking about when we're talking about giving this function, this care function, to an entity. So, to answer the question, how do we do it other than a plan? We can directly pay for the care coordinating time that doctors, if a doctor picks up the phone, we don't necessarily pay for the time that nurses expend going over the care plan with the patient. I hear that as a complaint from nurses and that I represent all the time, that they just simply don't have the time to give the education on the care plan to the patients. So we can make sure that we pay for those types of things, and that we can pay for the tools that a doctor or a medical group or a hospital needs so that they can access the different types of your health information, and so that they can give you proper referrals to other people in the system. I think those are different ways that we can directly fund those types of things. And I do think that paying doctors for the time that they spend managing your care is really important. We need to make sure that if a doctor spends this type of consultative type of time with you, that we actually ensure that you're paid for it. And I want to kind of make sure that when I'm talking about these criticisms of using risk-bearing entities, that we don't again fall into the false dichotomy between fee-for-service and risk-bearing intermediaries, because we've talked about this earlier, that there are other payment structures like global budgeting and salaries that we can talk about. So it's not a step back to decades past that we're really describing when we're talking about not using plans to coordinate care. And I think one of the issues again that we should remember is that these types of integrated care models, and we've talked about Kaiser a lot, and Kaiser has had trouble with they're being litigated against by the DOJ right now for upcoding, for trying to game the system. And I think we had to remember that when we're giving plans this type of power over the types of care that are provided to patients, that there are a lot of areas where fraud and abuse can happen because they're not providers, they're administrators. And I want to just highlight a couple of additional thoughts that I think we should remind ourselves about. When we're talking about putting people into types of integrated health systems or managed care groups or coordinating entities, whatever you want to call them, what we're talking about are membership-based networks. I think that is fundamentally a problem, because we're dividing the risk pool. We're forcing people to accept narrow networks. And we're saying, actually, we're not going to let you have choice. We're going to limit the doctors and limit your networks. And fundamentally, that means that there is not a single standard of care for all, because we're having these plans compete with each other. And I think, as others mentioned, there's administrative complexity when we have these competing plans, when we have third-party middlemen driving up the cost, because we have all these types of the paperwork of health plans. I know Professor Shao mentioned the paperwork of government when we have a single payer system, but we have the paperwork of health plans right now, multiple health plans, where doctors have to deal with all of this paperwork from dozens and dozens of health plans, where patients have to deal with it. And I think fundamentally, when we move everyone, if we decide to move everyone into enrolling into risk-bearing, coordinating entities, health plans, this really just means that we're allowing corporations to divvy us up and to compete over groups of patients. And what they'll end up doing, which we see today, is that they compete over the healthiest and they try to push out the sickest. And I think that is a fundamental problem, that we can't overlay this kind of this competitive economic model onto care coordination. It hasn't, and it wouldn't get us to better care coordination. It leads to fraud and abuse. It leads to coordinating entities strong-arming our providers to upcode or to improperly push the sickest out of the system to other entities. And for me, that it's completely unacceptable. We should ultimately give the tools and the resources to providers so that they can have the time and the resources to spend on care coordination, and the larger system-wide types of coordinating functions we can give to the system itself. This is why we have and want a unified system. So those things can be administered on a statewide level, whereas the things that need to be and should be done by your providers are paid for and valued by the system, rather than kind of this game of trying to incentivize providers to do one thing or another thing. We just need to really help our doctors be able to talk to each other. I know it sounds really simple, but I think that's really what fundamentally we're trying to get at when we say we want to coordinate care.
Thanks, Carmen. I will just pick up on, you said a lot of important things, but I think one thing Richard Ban said, you said this notion, and I certainly experienced it working both in San Francisco and LA, that when the plans begin to do a coordinating function and the provider feels the same responsibility, it actually doesn't get done well in either place. And so this idea that we have an opportunity to be really thoughtful about how these structures are set up and be clear on who needs to do what in each system, I think is a really key point that I think you both raised up. I want to go Richard Scheffler, Bill Shao, Peter, your hand's up. I also want to pull in Sarah. I know in prior conversations we've had sort of conversations on how much do we, in a plan-based system, do we have the opportunity to do certain other things like things around workforce, things about in closing gaps and disparities. Would love to hear your thoughts a little bit on kind of where you land in this conversation as well. But Richard Scheffler, maybe turn to you first.
Thank you, Mark. I want to start by saying now I know why Peter Lee has always been a big hero of mine, because down on the ground, he understands how the healthcare system operates. And I would just tell Peter that I do also totally agree with everything you said, except for one small quibble. I think the fee-for-service capitation argument is 45 years old with the Rand Corporation and not 40 years old. And to go back to that now would be lunacy for this commission to think in terms of that. So you're totally right. The evidence is overpowering and the field has moved on. Internationally, I think, I also taught international systems, so I have great respect for Bill, but Bill didn't point out that in the UK and in many parts of Canada, the primary care doctors are paid on a capitation system. That's basically the model, and they are paid per patient. They normally have around 2,000 patients or more, and they compete for patients and they get a capitation rate. And the hospitals are paid on block grants. They buy services for them, which is another form of capitation. So the world has moved on and on. The issue of profits in medicine bother me. I've written my own papers on that. I'm particularly concerned about private equity firms and big businesses making money off of healthcare. But I'm less concerned about nonprofits like Kaiser or Blue Shield. But the reality is, as Peter says, most of the doctors in California are in some kind of group, from small to big, and virtually 99% of those are set up for profit. Private practice means profit. Every doctor in California, unless they work for the state, is making a profit. They have a balance sheet and they make a profit. Their income is a profit. I can tell you that from teaching 50 years in economics, that when they file that tax return, it says at the bottom, this is the profits I made. And that is just a fact. But big corporate profits, well, maybe we ought to think about that in a very, very different way. So I understand the difference, but it's not the profits are a bad word. There may be some people who have some concerns about big corporations making profits and healthcare plans being on the stock market and making money, and we can talk about that. Richard, Pam was right on. I mean, you can't talk about care coordination unless you talk about how you're going to pay for it. Coordinating what? You can't coordinate a fee when you come in and pay for a visit. There's no care coordination there. And adding that on, how much would you add on? I mean, there's just no way of doing that. Care coordination means everybody working together, not on a fee. So you go back to the field has told us it's the capitation payment. It's the way you pay for things. And it also gives us a very powerful, super powerful tool for dealing with disparities in the healthcare system, because these capitation payments can be geared to address the disparities in the system. And I know Medi-Cal is working on this and paying for things like transportation. They're thinking about paying for things like housing to coordinate across sectors, and that's all done in a capitation system. You can't put that into a fee-for-service medical system. It makes absolutely no sense at all. I will give you my personal preference. I don't think the state can coordinate care. I don't think it's a function unless they say that every doctor in California works for the state. I don't think we're about to do that. I don't think that the healthcare system wants to be a state employee. And so the state can set, I think, guidelines. It can incentivize things by the way they pay. But down in the ground, I think it has to be done by the providers and working with the healthcare system. Providers, doctors don't run hospitals. They can't. So someone's got to run the hospital. Someone's got to run the. As good as you were, Mark, you weren't running the hospitals in San Francisco and LA when you were coordinating. You were down on the ground working about coordinating the care for the patient. So there has to be some higher level, some organization that coordinates hospitals and doctors and other providers in the system, nurse practitioners, whatever you like. And so that has to be structured and it has to be paid for. It doesn't happen accidentally. And the model we've developed in California, which is the secret sauce of the healthcare system. 75% of our individuals in California are in some integrated delivery system, as described by Sandra Hernandez, I think beautifully, and using data exactly that way. When I go on my chart, I see everything. And the doctors see everything. And basically, that doesn't happen in a fee-for-service system. So, you know, my hero, Peter, said it a lot better than I, but I just wanted to weigh in and say, I'm totally on board with what he had to say, and others as well, as you've heard.
Thanks, Richard. Bill Shao.
I just would like to compliment both Sandra and Richard and for sharing with us what the front line, I call front line doctors faced with when you think about the coordinated care. And I'd like to just clarify, I assume we're talking about the coordination of care, at least in two major dimensions. One is coordinated care between behavioral health care and the physical care. We had a whole session that Sandra and others enlightened us on. And the second is coordinated between primary care, specialty care, secondary care, tertiary care, and rehab, and maybe even with social services, which provide advice on social, like housing, nutrition, and food, so forth. That's a big challenge. So to me, in this report, I would suggest you consider there are two major forms. One is you organize this coordination within an organization. I think everybody agrees, as the question you posed, you need an entity. So one is the organization, internally coordinated, like Kaiser. Other one is I call the externally coordinated. And what's mentioned by UK, they require the primary care, the GP actually coordinated care. We can debate how well that works out, but that's the whole design, is have a small group of primary care, and ACO was mentioned. That was also the concept they thought they can integrate from bottom up. But if you use external, then you have to you have to rely on contracts. Okay, internally you organize differently. You use employment, you use promotion, you use corporate culture, and so forth. Deliver to provide that coordination, I will argue. So to me, the commission should really maybe bring this out. Now I like to echo and support. You're not going to do this just through directives. To make it work, you have to create the right incentive. On capitation to an organization, that organization is responsible for it, then you can hold that organization to be accountable for the results. Or you have to then give the capitation to the, say, HCO or GP fund holder like England has. And then you can hold them accountable. So I like to add in the word, you have to hold that entity accountable for the results. For the results you expect to produce through the coordination of services. That's only a means to an end. You want to improve the health and health care of the people. You want to hold them accountable for that. That's the 2 cents I like to add.
Thanks, Bill. Peter, your hand's up, and then I'm going to go to Sarah.
Yeah, just very briefly, just a couple things. One, I think Carmen noted a couple really fundamental things that any unified financing system should make sure to address. The issue of clinicians guiding clinical care and not being driven by non-clinicians. Absolutely essential. Similarly, to not allow any entity to benefit from avoiding sick people or trying to get healthy people in. Now that used to be American healthcare. The Affordable Care Act got rid of that. And it's still on the margins in MA, but in the employer sector, like it or not, and I don't like a lot of it, health plans take everyone in an employer, sick and unsick, and they have to care for them. So, but as a fundamental issue, if you're going to have entities, and remember, 99.9% of doctors, of nurses, of therapists are in entities. We pay entities, and hence people get salaries, they divide them. So we're dealing with entities no matter what. How do we make sure any of those are rewarded for what we want, which is not gaming enrollment, but it's providing better quality care? And so I think in some ways what we're talking about now is what are the rules of the road? And those should be essential. The other thing that I think is the challenge is how much do we want to plan a new system based on theory versus on evidence of what's known to work? And this is where many of us have done a lot of looking at trying to promote better primary care through patient-centered medical homes, et cetera, and hasn't shown the lift we'd all thought it would on quality. So to say we're going to create something we don't know and have that work in the future, there's a lot of unknowns here. I just encourage all of us to look at the evidence at each step along the way. But clearly the evidence is, without oversight, plans, and I'll put in air quotes, both nonprofit and for-profit, historically sought to win by risk selection. They can't now. A unified financing system shouldn't allow it. Delivery systems should be driven by clinical care and what's right for patients. And that's what the guidance should be framed. So I think these are really important sort of just fundamental principles that I just want to echo some of what Carmen was saying, but recognizing that, every entity is driven by incentives. Every entity is out there that has a mix of providers steering one way or the other based on where we move the money. I hate to say it, but folks follow the cheese. And a unified financing system needs to look at how we're setting up the financial structures to reward and demand global responsibility for a population. If we don't do that, we won't get it. And that's what we've seen over the last 20 years.
Thanks, Peter. Sarah, go to you next, and then Don, I'd love to pull you in to the conversation as somebody who's sitting at the center of some of these conversations with plans. Would appreciate your thoughts as well. Sarah, you first.
Great, thank you so much. I think everyone has said so many brilliant things, so I'm going to probably pull out a lot of what the other commissioner said. But the first thing I'm going to say, not to nerd out, is that all of this is so dependent, and it's just striking to me about how we're going to need incredible, granular, and robust data collection and a really good IT system to support this. Because even if we're talking about care coordination, part of the big issue is like, do people have electronic health records that follow them around? And so breaking down those barriers first is going to be so essential. And I just think we can't emphasize that enough, that that's going to be the backbone of the system. The second is that I just want to, so many people have said this, Professor Hsiao, like holding people accountable and how inseparable payments are from all of this. Payments in terms of care coordination, but also ensuring, I think that payments are also key to quality improvement and ensuring equity. And so whether that is rate setting or negotiation, there has to be an awareness that payments do more than just pay providers in the system, that they help us achieve our goals and they help us hold people accountable. So that's a big piece. And then the other thing, I definitely agree. I think there's such a huge role for primary care providers and clinicians in coordinating individuals' clinical care. Part of a challenge with that is that you're not going to have the ability to coordinate care if you don't have enough clinicians. And so again, we run into this workforce issue of, okay, we need enough trained primary care providers in all areas of the state and the support team. And so there needs to be, and partly I see that it's not as the cloud, but that other big square up in the corner of, we need to use this data to make sure that we have the workforce distributed in a way that it needs to be. And then I think, there's the individual, we're going to coordinate an individual's care, but then there is this larger question, and I don't know if it's care coordination, but it's something that I think good examples of this are in Kaiser as an integrated delivery system, which, for a lot of unions that represent low income immigrant populations, we have the majority of those workers going into Kaiser because it is kind of an internal system where you get that support, and you're not just thrown out on your own in the sea of all these different doctors. And then also CalPERS. And I think both of those are systems where they expect that they are going to have their members for life. And so it's a different obligation. It's not just coordinating an individual consumer's care, but it's like, we have to look out for the population health of these patients as a group. And I think there's something to be said of coordination on that level, and whether it's Kaiser and all they did around getting people to stop smoking. Their smoking cessation programs, which wasn't about just one patient, it was about their patient population. Or what CalPERS has done in terms of getting people to higher quality, lower cost providers, or looking across the system at like, where are we falling down on health equity? Where do we have these disparities? Where do we have, you know, maybe there's like real variations in quality. And so I do think if that's the role of, as people said, hospital administrators, if that's the role of a regional entity that's looking at trying to do it, if it's a Kaiser model, I just think there's something beyond just individual patient care coordination that's really key too. And maybe coordination is not the right word, but it's that level almost between the unified financing directors and the clinician that we just, I think is really important on every level for the system.
Sarah, super helpful. I think you underscored some important things. And then just, and this, I thought Bill was going to go there with his 2 levels or two forms. But you added to Bill's point. I think there's the individual patient care coordination, and then there's what Sandra talked a bit about, and Richard Pan mentioned it as well, with population health, just these responsibilities, and then the point about accountability, can't emphasize it enough. All right, Don, and then Anthony, you have your hand up. Thank you. Would love to hear from both of you.
Yeah, I'm really struggling for anything to add. A lot of good comments that certainly captured anything I would say. You know, certainly agree with Peter about the importance of care coordination. We see it in our own plans. Our PPO product is higher cost to us, higher cost to our members, particularly when you look at cost sharing. It is challenging to meet our quality standards with PPO because of the lack of coordination. We see that in our own quality reporting from plans. The literature supports everything he said about the health effects of the 2 models. And Sarah's point about us caring, you know, potentially as much as anybody is a point really well taken. You know, we have folks who start working for the state or a non-state governmental entity in their 20s or 30s, and they die in their 80s with CalPERS retiree healthcare. So anything that we're going to be doing to do a better job of managing the quality of care over a lifetime and costs is going to require coordination, and that commitment early on is something that we're going to see later on, and is essential for us to be able to sustain what we do now over time. So again, like, you know, lots of great comments. I think violent agreement to just about everything that was said in support of really figuring this one out.
You said 2 important things, Don. The PPO piece, I think, is really important. We don't talk about it enough, and that's a model that just hasn't really panned out. The fallacy of the PPO is getting more common. And then you use the word violent in a way that I wouldn't have otherwise used it. So I'm going to endorse that use. Violent agreement is nice. All right, Anthony, you're up.
Yeah. So it's one of the, so I appreciate, Mark, what you laid out in terms of that graphic and just sort of trying to get to another level of granularity. And I think maybe this conversation suggests that we can maybe go one more level down in terms of detail with regard to this. On the surveys, I was probably more on the spectrum of, spectrum of skepticism with regard to the plans or intermediaries that look like plans, because of both the skepticism of the for-profit motives that Carmen referenced and the actual track record that Peter referenced with regard to having not moved the needle on right time, right care, right time. But I do think that but I absolutely think that we do need a coordinating role. Like, it is not my ideal system to just have everybody have theoretical access to everything, but not have guidance, direction, a home, the ability to have a coordinated approach to whatever ails them, whether it's team-based care. And I think, and I do think that we've said care coordination in a couple different, Bill, Sarah said it, I'll say it a different way, which I think there is that sort of bottom up of the navigation of just helping people through the system. And I think there's the system coordination, which is, one of my goals is I would love, right now the incentives are not in place. The ACA did the right thing by saying that we cannot deny people for their pre-existing condition, but I would love for us to have a system where providers or systems compete to be the world-class entity to take care of diabetes, the list that Peter mentioned and others, of diabetes patients, of heart disease, of obesity, and the incentives are not quite there. And so, how do we do that so that they're competing on that front? This is a role that the providers, that sort of system, that requires a care coordination about how do you organize the system to make the most sense for those types of patients. And so that's something that, you're, as much as I want a system that has navigators and has, people helping, I also want folks looking at it at the top level to change and adapt and have those systems be developed. And I think that may need some regional approaches, because I do think we are blessed to have such a diverse state that could be 8 or 10 different states in itself. And how do you recognize those very real differences in both the infrastructure and culture and just the needs of those different areas, and make sure that, while not creating inequities between them, but recognizing the needs that the rural areas have, or the Central Valley has, versus the Inland Empire or the coasts. I would say, so but I think the other thing I wanted to just say is, one is a question of transition, and maybe one of politics, which is, I think, there is a version of trying to move to a single payer unified financing system where you say, we're going to change the financing system, but because people might be scared of that change of the financing system, we're going to try to keep much of the rest of the system at least intact initially, right? Like a version of, if you like your doctor, you get to keep it, right? Kind of, and I think in California, people may ask, I don't think people have fealty to their health plan, but they might have to their system if they're the medical group that they've learned to live with, whether it's Kaiser or 5 other places. And so there's, I think, one version. I think there's another version. I think it's just a decision to be made about whether you also want to say, and this is a system that will also change the system in significant ways, or how much do you use the networks and systems that the health provider, the provider groups and systems that exist, or how much do you change them, or at least create incentives for their change and improvement? Because we do want to get to an improved delivery system. The question is, how do you sequence this in an appropriate way? And I think that's a decision to be made. And it's a trade-off, because at one level you do want to show that improvement, at another level you do want to, if you're disrupting some parts of people's lives, even with the promise of improvement, you want to give some sense of security. And I'm not saying I have an answer to that. I just think it's a question that we should address.
Thanks, Anthony. I want to, Andy, I'm just thinking about a question that you've raised a bit. It's on the slide that Jenny asked us to pull back up. I won't ask us to put it back up, but on transparency, I think we talk about accountability. We talk about all the data. One of the things that you have certainly brought up time and time again is the work that you're doing around transparency and how that drives not just improved scores, but informs people about what they're actually getting. And I'm curious what your thoughts are, especially on this point, because for all of the work that we would put in to get the right data system, to have the information available at the patient level to the providers and the patients to coordinate better, there is this broader sense, whether it meets some of the population health goals that Sarah, you talked about, and help us understand where we're going on those, just this issue around transparency and how this entity plays a role in that.
So thank you, Mark. And I'm sorry to be a pain in the butt on this, but I do think it's important to accountability, like wherever we land on the care coordination structure, the relationship between that, the providers and the state unified financing authority. I think everybody is agreed there needs to be accountability for whoever is responsible, right, for results. And I don't think that accountability can happen without transparency to the public around what's going on with the patients. I don't know that transparency in and of itself is sufficient, right? But I'm pretty sure it's necessary because there aren't enough monitors in either a state financing authority or a care coordinating entity to actually stay on top of what's going on. That's just reality number one. The second point is, once information about, say, use of services in a specific population, does that meet the metrics we've set up for improvement of that population's health? Once it's clear that information is going to be made public and that everyone can see it if they want to, then the regulators, the care coordination entities, the providers, everybody knows that's going to happen. And at the margins, some of them are going to up their game. And that in and of itself seems to me a very important value add here. You're collecting the information anyway. To Sarah's point, you've got to have a good data system, and Sandra's. Once you've got that, get the results of that data de-identified. Don't care about patient names and social security numbers, but get the results of that out so that everybody can see who's performing and who's not. And unfortunately, I don't have enough research on this yet to show you that actually there's been some success from this, because the world is pretty opaque and California isn't alone in that regard. But my hypothesis is that if that information were out there, you would get improvement on the part of all the actors in the system who care about their reputations, who care about their professional standing. And there are a lot of those. And they will up their game. I do want to say that I had a chance to look at the RFP that Medi-Cal put out, and there are some real advances in that, and maybe over the next couple of years, if you guys stay the course, we'll get to see whether this works or not. But I was very encouraged by that. Thank you.
Thanks, Andy. I didn't want to promote self-promotion of Michelle and her organization on that. So thank you, Andy, for raising it. Okay, Richard, 60 seconds or less, please. I was going to wrap us up so I can give us 10 minutes or so around Carmen's good question on the final report, but go ahead.
At some point, Andy is going to tell us of what that Queen of Spades means in the picture behind him. We don't have time for that now.
We can talk about that offline, Richard.
I'm sure there's a good story about that. But I think the other thing that I agree with the care coordination thing, there are different levels and one has to think it through carefully. But the other thing that I think the commission really needs to weigh in is on on the issue of profits and nonprofits and the healthcare system, and where we think it's appropriate to make profits and maybe not appropriate. It's a value judgment. We do know we live in a capitalist world, and you can't take a healthcare system and make it different than the culture and the country that you live in. So in thinking through that issue, it's quite important for us to understand that virtually everything in the United States has to do with, is driven by the profit motive and in fact the economy. The big question is, what's an ethical, reasonable way of making this profit by improving care, improving efficiency, and not making profits because you have various market power and you can enforce your will on the healthcare system. So the structure of the healthcare system and the power that various groups has is quite important for the state to be able to go on. This is a trivial example, but I don't have much time to think of a better one. If you had a life-threatening letter that you had to send to a loved one, would you drop it in the post office or would you send it Federal Express? I think you'd send it Federal Express or DHL. So there are various things that the for-profit healthcare incentives do better. And we need to think those through carefully. And I think it's an overarching issue, and we just need to decide it. I don't think it's one or the other, but I think it's an issue of when we think it's helpful and will improve the healthcare system, and when we think it's not acceptable. We don't allow people to sell their organs on the free market, even though they may want to. So there are ethical judgments that the state and this commission can weigh in on when it's appropriate to make a profit on something and when it's not. So I'll just stop there.
Great. Richard, thank you. And I'll just, without a lot of time, I'm not even going to try to summarize what was a very rich conversation. I will tell you this. I'm glad I brought it back up. I got a lot of helpful information, as I said, and by way of transitioning into a conversation about the final report for just a few minutes with all of you. Part of why I've raised these two issues is, as I've been working on the draft, these were areas where it was clear we needed a little bit more substance, a little bit more weighing in to be able to have the direction of the report end up where I think we can all be proud of it. I think we raised a lot of important points in this part of the conversation, some key attributes of care coordination, agreement that it needs to be done by somebody, that the idea that it gets closer to the patient and falls in the hands of providers could be a good thing if they were equipped with the people and the tools and the data to do it, but that accountability and transparency matter in this space as well. So I don't know that we came up with a, hey, everyone loves this version more than that version, but I didn't expect that. What I expected was to get a lot more information on how we might suggest we take this on as a next step within the work that lies ahead to get us to this system. And I'll just end by saying one of the things I've really enjoyed about all of these meetings is, we talk about unified financing, we talk about single payer, but really the emphasis is on a system that just does a whole lot better for patients. And I appreciate that in every commissioner's comments, right? What I think we're doing here is trying to reimagine the healthcare delivery system and understanding how that gets supported through payments and incentives or whatever you want to call them, and how those dollars come together and get distributed out. But the fundamental bottom line for all of you, which I'm grateful for having each of you on the commission, is this interest in driving a better bargain, a better set of conditions, a better set of health outcomes for the people of California. Sort of in that sort of transition to the report, then We'll also say that I think it's just today, the December, or maybe it was yesterday, the results from the December survey are up. I hope you'll take the time that I know I did and others to take a look. I think it is informative. It helps us get to the questions we were raised today and then other questions. And these surveys have been critical to helping us get to sort of coordinated form for the report between commission meetings and the contents we've discussed over the many months of meetings, but also these surveys, which give many of you a chance to weigh in a little bit more in some ways and in a more targeted way. So please take a look at that because it will inform the final report, as I said. So I wanted to just take 5 or 6 minutes because I don't want to take more out of the public comment period, just to take some questions. I'm not sure that I'm going to answer them all. I will somehow, some way, and certainly take them into account. But here are your questions about the report, if there are any. Carmen, I know you said you had one, so I'm going to turn to you first. And if we have time left over, I can turn it to other people as well.
Thanks. I have a couple, so I'll just kind of rattle them off. You know, are we going to be able to make comments like we did in the environmental report to attach to the final report? And then procedurally, I wasn't sure. So are we discussing the draft report in April, or is it going to be finalized and then no additional changes are possible afterwards? And then for the draft report, will the draft report be made public, or is that only the final report? Because I do think that folks in the public would want to be able to weigh in on you know, potentially changing the draft report if there's something that's you know, inaccurate about public comments or whatnot in there. And then on the legal memo portion, I'm just wondering whether or not that's outside counsel or within CHHS or you know, who's actually doing this legal memo, or the consulting team, or you know, if the consulting team is doing it, or if it's actually you know, attorneys who work in the field of Medicare and Medicaid waivers.
Yeah, so I can try to answer as many as I can quickly. First, the draft report will be made public the same day that all of you receive it. And we look forward to taking comments as we have from the public on that report. The strategy to sort of both provide ample opportunity to weigh in broadly, but also to get targeted feedback around specific areas is going to be through a survey, just like we've done with surveys. You know, they target a specific issue, and it's opportunity for all of you to provide some additional feedback. Those comments, survey results will be made public, just like they have in these other opportunities. The legal memo is by outside counsel. Don't ask me which counsel because I can't remember the name, but that will be available and you'll see who did it. And then in terms of process, again, March 15th-ish, you know, day before, day after, you all will receive it. We give you a full couple of weeks to provide your feedback through the survey, and there'll be ample opportunities to go more broad. If there is clarity for me that we have to do something else, I will always call the audible, just like I did here. We didn't expect to kind of have this meeting. I was working on the report. I was like, we need to add a few more content conversations. We'll see where it goes. But you know, right now the consideration is we take that feedback, integrate it into the report, provide a final report a week before we have a meeting so people can digest it, and then we would come together and talk about it. I never say, you know, that I can predict with tons of clarity where this will all go. This is our best attempt at putting around a process that helps us get to a finish line. And so, you know, always happy to take feedback along the way, but that's the current plan. I hope that answers most, if not all of your questions, Carmen. I want to definitely wrap up in 2 minutes. Are there any other burning questions about the report process or any other questions by others?
I would just say that on the outside counsel, I appreciate you doing that. I do think that will help the discussion. I do wonder if it's one or if it's one maybe working with other firms, because the firms that work on, say, Medicare waivers might be different than the ones that have expertise on, say, ERISA, right? And so just acknowledging that the deep dive expertise on the various different things we want might be in different places.
Yeah, I guess, I mean, Anthony, I appreciate that. What I will say is, we're going to do as much as we can before the final report is out. And then the final report is going to have a section, and the part that I hopefully we build up to is what do we do next, right? Like, what are the concrete next things? And some of it may be, I know people don't always love it, you've got to commission a little bit more work, and maybe that's part of it, Anthony. So I'm curious what people will say based on what we attach to the draft, and then we're open, right? We want to make sure that the next steps, the next phases represent what this commission feels like we should be putting our nickel on. And that may be part of it. Okay, we have come to the time of public comment. I would just say thank you to the commissioners. Very rich conversation again, very helpful for me. And I will turn it over to Karen to help us listen to the public's feedback.
Thank you, Secretary Galley. It is now public comment period. We are opening up the chat feature for real-time written public comment. And as many of you have already done, we will be inviting verbal comment by looking at the queue in the participant panel of raised hands. If you don't yet know how to raise a virtual hand, you click on the reactions button at the bottom of your Zoom screen, and you'll see another button that says raise hand. When I call on you for verbal comment, please unmute and state your name and any relevant affiliation. I will be keeping a time clock of 60 seconds per speaker and ask that you self-monitor to stay within that time. Please do forgive me and understand. I will ultimately, after warning you, mute you if I have to so we can move on, just for the sake of fairness with so many people wanting to speak and limited time to do so. All right, with that, I'm going to invite our first member of the public for verbal comment, Peter Shapiro.
Yeah, I'm with the California Alliance for Retired Americans in Healthy California now. I'm also a pretty much lifelong Kaiser patient. And I don't share Peter Lee's rosy view of Kaiser. I've seen it at its best and its worst. I think it's important to realize that Kaiser is really three different entities, and it's important that we not confuse them. You have the Permanente Medical Group and the Kaiser hospitals, which actually treat patients. And then you have the Kaiser Foundation Health Plan, which holds the purse strings, which decides what kind of coverage, what kind of treatments are covered, what kind of co-payments are going to be demanded, where the facilities are going to be located, and so forth. Unfortunately, the people with the purse strings make the critical decisions. When my doctors at Kaiser are allowed to do their job, when they can work collaboratively, they can do very good work. But I want to share this. Last year, I looked up Kaiser's plans, and I discovered that on the state insurance exchange under the Affordable Care Act, it lists no fewer than 26 Kaiser non-group plans: 6 bronze, 10 silver, 6 gold, 4 platinum.
Thank you, Mr. Shapiro. Thank you, sir. I'm sorry, if you might be able to finish your comments in the chat, I'd appreciate it, just because we have so many more people who would like to comment. And with that, I'll turn to Leah Schwinn, invite her to unmute.
Hi, my name is Leah Schwinn. I'm a member of Healthcare for All California. I appreciate Commissioner Scheffler bringing up the issue of profits and corporate profits. But what I want to say is, when he talks about a doctor making a profit, everybody wants to be properly compensated for their work. And they should be compensated well for care coordination. Our doctors right now are dealing with all kinds of technology, dealing with multi-payer system. They could certainly handle a state-run coordination system. And I think we need to talk about how the problem with the corporate profits and having a corporate entity do this is that they've gotten outrageous profits. They've gotten up to the point of obscene profits. There is no ethical balance between making a profit and being fairly compensated.
Thank you. Thank you. I'd like to invite Patty Harvey to speak.
Well, I would just like to reiterate what Leah just said. My name is Patty Harvey, and I'm with Healthcare for All California and Physicians for National Health Program in Humboldt County. And there is a big difference between doctors making a profit and corporations making a profit. Corporations deliver nothing. We all know very well that the less care that they pay for, the more money they make. And one prominent corporate administrator recently was heard saying that our most important metric is revenue, not healthcare, not saving money for participants, but revenue for the corporation. And these corporations have been fined over and over again, millions of dollars. They don't care. It's a slap on the wrist. It's the cost of doing business. We have to make sure that corporate profit does not become an impediment to healthcare. And now we have such as the direct contracting entities, which are
Thank you, Ms. Harvey. Thank you. I'd like to invite Jamie Maraviglia to unmute.
Hi, yes, thank you for the opportunity to speak. My name is Jamie Maravilla. I live in San Luis Obispo County. And I just wanted to share my personal experience with cost sharing. I'm a state worker. I'm under a CalPERS PPO plan. And a lot of people would consider that great insurance with low out-of-pocket costs, but I've learned over the years that that is all relative. I have a daughter who was born in 2017 with a congenital disease called Hirschsprung's disease. She basically does not have a functioning large intestine and has had multiple resectioning surgeries and is frequently hospitalized for dehydration. As a result, we have racked up over $25,000 in medical debt over the last 5 years. And while we are slowly paying it off, it affects almost every aspect of our life and influences all of our financial decisions. The worst part to me is that every time she gets sick, my thoughts automatically go to how much it's going to cost me rather than being able to focus on her health. And we question if we should bring her in. We don't know if the symptoms are life-threatening or not. And I don't think it's fair that I always constantly have to think about those decisions. I shouldn't be put in that position to know if I can afford it. Thank you.
Thank you so much. Michael Leidy, please go ahead.
Thank you, Karen, and thank you, commissioners, for another enlightening discussion. My name is Michael Leidy. I'm president of Healthy California Now. I share the concerns about cost sharing and its effect on patients receiving the care they need and deserve. Even small out-of-pocket costs deter care, and the administrative costs may outweigh the savings. See the Peary study from 2017. Let's remember that the only appropriate cost sharing is based on ability to pay, which is what progressive taxation does. So it's not true that there's no cost sharing, since virtually everybody pays something under that system. Finally, I think based on the pandemic experience and other public health issues, we've seen regional variations in things. And I think this suggests there can be a useful role played by regional authorities in the functions that we want to do in terms of coordinating entities. And such approach was envisioned by SB 810 and SB 840, and that could provide a guide that I suggest you consider. Thank you very much.
Thank you so much. Bill Honigman, please go ahead.
Thank you. Can you hear me?
Yes, sir.
Okay. Yes, Bill Honigman from Orange County. I'm a retired emergency room physician who worked for Kaiser Permanente for over 30 years. I'd like to say that the copays and deductibles implemented there in the later years of my tenure were a disaster. These perverse cost-shifting tools served only to push my patients to delay their care and produce hostility that became directed at the caregivers, further promoting distrust and a further disruption in an already strained patient-provider relationship that I witnessed to be getting worse every day that I was on the job. It also was a perverse business model for a provider group that claimed to be about keeping their members healthy, as recommended tests and treatments were refused by patients when faced with what they thought was an unaffordable personal expense. And finally, Dr. Galley's summation of this issue of cost sharing. I may have missed it, but I didn't hear him mention specifically what would be the elevated costs due to delay or refusal of care. This
Thank
is
you, Mr.
absolutely.
Honigman.
Thank you.
Thank you, sir. Terry Winter, please go ahead.
Yes, hi. I'm a registered nurse as well as a graduate of Dr. Scheffler's department at Berkeley and the co-chair of the Healthcare for All Working Group in Sonoma County. And I spent decades actively involved in designing and implementing care coordination in the Bay Area for Kaiser. I witnessed dramatic improvements in health as well as in the delivery of care. And I agree with Commissioners Lee, Chan, Hansen, and Bass of the need for high quality team-based accountable systems of coordination of care. Yet we need to remove insurance components that suck billions from care and create incentives that eclipse that needed care. I'm a passionate supporter of single payer system as the only way to create an equitable, high quality and sustainable system. A single payer system that removes the insurance intermediary and integrated high quality coordinated care need not be contradictory. We need both designed into a unified financing system. Thank you.
Thank you, Mr. Winter. Beatriz Sosa Prado, please go ahead.
Good afternoon. My name is Beatriz Sosa Prado. I'm the Executive Director of California Physicians Alliance, CAPA. We believe that healthcare is a human right. CAPA was founded in 1987 by progressive physicians in the Bay Area with the mission to reform our healthcare system and achieve single payer. Our approach to improve the healthcare system is short, medium, and long-term. Since the ACA's implementation, CAPA has supported it. Our student organization, the California Health Professional Student Alliance, our future healthcare leaders, now assist individuals and families enroll in health plans with the support of Covered California. CAPA organizes California physicians and amplifies their voices so their legislators could hear from them by supporting bills and legislation that improve the healthcare system. We believe that we can reform our Golden State healthcare system and make it the best in the nation. That is why our long-term goal and mission is to work with others to create and achieve a universal healthcare system in California. What we call the system.
Thank you, Ms. Sosa Prado.
It's irrelevant. We need universal healthcare. Thank you.
Thank you. Thank you. William Bronston, please go ahead.
My name is, wait a minute here, hold on a second. My name is William Bronston. I'm a physician. I was the medical director for 2 state departments in California for 25 years. First of all, to commodify and monetize suffering and illness is barbarous. The rest of the world that is capitalist has universal healthcare systems and national systems in place, and nobody is talking about capitalism as the rationale for changing that. We must put an enormous amount of money into a public health development system. Our public health system is crippled and has been so since around 1980, and that should be a top priority. We need to decentralize the empires of our system in order to return care to local levels, to neighborhoods, and to blocks. We need to radically change the workforce in the system to develop cultural sensitivity, to expand and build capacity to work in the health deserts, and fundamentally to establish a California health core for providing insurance and, tuition coverage for training. We need single payer, we need CalCare, we need to really look at a much larger picture of a healthcare delivery system, not a wellness versus a death system.
Thank you, sir. Linda Bahara, please go ahead.
Hi, thanks so much. My name is Linda Bahara. I'm a physical therapist and I live in Contra Costa County. As a healthcare provider, I really want to emphasize the fact that people avoid needed care, even with low levels of cost sharing. I frequently see patients recovering from major orthopedic injuries like car accidents or fractures who self-limit their own rehabilitation care because of copays of even $10 or $15. When patients avoid proper rehabilitation due to cost share, they're much more likely to develop chronic pain and chronic conditions, which in turn leads significantly higher costs down the road, not to mention the needless pain and suffering that causes. And I see this every day. This is the true cost of cost sharing. The only equitable solution is zero cost share at point of service under single payer healthcare. Thank you so much.
And thank you. Craig Simmons, please go ahead.
Craig Simmons, and I would like to propose a vote by the commissioners to draft legislation for inclusion in the June 22 primary election or the November 22 general for inclusion of a ballot measure to implement a payroll healthcare tax and a corporate wealth tax to fund a unified financing system. Thank you.
Thank you. Just looking ahead, we have about 6 minutes or so left, so I'll be taking 5 or 6 more verbal comments. So if you see yourself further down the queue, please be sure to take some time to enter your comments into chat or to email us at healthycaforall@chhs.gov. And with that, I'll turn to Robert Skinner. Please go ahead.
Thank you. My name is Robert Skinner. I live in Atascadero, California. I'm a retired high school history teacher. For 26 years, both my wife and I worked for a school district. We were both self-insured. We did not have to pay any expenditures or anything. Proponents of cost sharing claim it is an unnecessary measure that will reduce costs and for redundant visits to the doctor's office. I think this is a wrong-headed comment. First, even though my wife and I were dual insured, we never had the time to take off to go to work for a non-essential or elective procedure. People only go to the doctor when they are sick or when they want to prevent being sick. When your kids are sick, it is essential. Second, when I turned 50, my primary care doctor recommended I get a colonoscopy. He stated he had no reason to believe I had colon cancer, but it was a preventative measure. Because I was dual insured, I didn't have to pay any copays. I went ahead and got that. 3 polyps were discovered. If I did not do that, I would be having cancer. I might not even be here today.
Thank you, Mr.
Compare
Skinner.
myself to my colleague who was under the same circumstances as I. He was not co-insured. He did not get a colonoscopy. 3 years later, when he was 53 years old, he died.
Thank you, Mr. Skinner.
That's it.
I'm sorry, Janice Rothstein, please go ahead.
Thank you, commissioners, for the public hearing and this comment section today. I am a California licensed vocational nurse and a member of National Nurses United. Business models of healthcare provision make as much sense as subjecting fire departments to the vagaries of the risk-bearing private business market. Rationing and denial of care already occur today under our system of private insurance. It's often self-imposed, as you've been hearing, because people cannot afford health care, the main purpose of which is to enrich stockholders. Even those who do have good insurance, even the best insurance, delay care because they cannot afford the onerous burden of co-payments, deductibles, and premiums. Because these 3 barriers to care would be eliminated under a properly designed single-payer system, self-imposed delays in care related to affordability would no longer occur. So-called abuse or overuse of healthcare services is an insult to the US public. Government-financed and operated single-payer systems in comparable economies around the world post magnitudes better health indices than the United States,
Thank you.
Number 11. Thank you.
Thank you so much. Bryn O'Neill, please go ahead.
CNA. A single-payer system can directly pay for the coordinating functions that integrated delivery systems claim to provide. But integration of corporate interests through risk sharing is not necessary to have care coordination. Through direct payment methodologies, a unified financing system can reimburse providers for the tools they use to let patients book appointments and view their medical records, for communication systems to help providers within the institution coordinate, and for time for doctors to talk to each other. We can keep the coordinating functions of integrated delivery systems while getting rid of the deadly parts of existing integrated healthcare corporations. We must get rid of risk sharing that incentivizes cherry picking and care denial. We must get rid of the closed networks that prevent patients from choosing their own providers and may make it impossible for rural patients to find a provider at all. We do not need restrictions on care to get care coordination. Thank you.
Thank you very much. Ellen Carroll, please go ahead. You're still muted.
There we go. Thank you. I'm Ellen Carroll. I'm with Healthcare for All, and we are part of the coalition with Healthy California Now. And it's very exciting to think of what's going to be possible with unified financing, which for us means a single payer system. On the subject of cost sharing, progressive financing of our healthcare system can easily provide adequate funding for a great system without the need for cost sharing, which undermines administrative simplicity and equity. And on care coordination, recognize that the role of care coordinator was left out of the latest single payer bill. That had been envisioned that coordination could occur in many places, depending on the way people got their care, including from primary care doctors. And I was just disturbed that the previous commission discussion, which I thought was helpful about the need for certain populations, including patients needing behavioral health support, has somehow morphed into blanket endorsement of plans and ACOs, which contribute to fragmentation and limited networks, which we need to move away from.
Thank you very much.
Thank you.
Thank you. And Robin Sunbeam, you'll be our last verbal speaker. Thank you.
Hi, I'm Robin Sunbeam, and thank you for allowing me to speak. I'm a member of NNU, of National Nurses United. Healthcare for profit is a crime against humanity. We have a moral imperative to provide Californians with healthcare, which is not access. The point of providing healthcare is to serve people and not make profit. Cost sharing under unified financing is about reducing utilization while maximizing profits. This is the opposite of the moral imperative to provide health care. Prevention and health promotion using primary care saves money by avoiding and mitigating illness. Instead of cost sharing to control costs, a single-payer healthcare system will reduce costs with streamlining, removing the administrative bloat and profit-seeking middlemen, bulk purchasing of prescription drugs, and guaranteeing the ability of all Californians to receive primary care without having to consider their ability to pay for it.
Thank you, Ms. Sunbeam. And with that, I'll turn it back to Secretary Galley to adjourn our meeting.
Thanks, Karen, and just really grateful for the public's comments. As always, helps us sort of hear a set of views. I know there's more in the chat that we'll get a chance to review as well. So as we're at time, I'll just thank the commission again for your thoughtful comments today and your participation in that conversation, and for the public for tuning in and sharing your thoughts at the end. Look forward to seeing you all again in April with a lot of work happening between now and then. All right, have a great afternoon.